Lakshmi ma'am.
Sheila madam, can we start? I think she said yes, na? So, good evening,
yes,
friends.
so we can go ahead.
Yeah, I welcome you all for day 2 of our certificate course on abnormal uterine bleeding. And today, I invite our chairperson elect. No. नीलिमा, तुम स्लाइड आगे आगे करो. Yeah, we welcome and we thank our FOGSI President, Dr. Bhaskar Pal. And I would like to invite our chair-elect, Dr. Ashok Kumar, for his welcome address. Ashok, are you here with us?
I think sir will
Next.
join in between, ma'am. Yeah.
We will. Next. We have our Vice Chair, Dr. Sadhna Gupta, with all of us. Sadhna doesn't need any introduction. We all know a thorough academician, humble, and always willing to help each and every one of us. Sadhna, the floor is all yours for your pearls of wisdom.
Thank you, Dr. Lakshmi. A warm welcome to all the faculties and all the delegates. On the second day of the
message
it's our own minima. So a warm welcome to all faculties, all dignitaries, and all people who have joined for this ICOG your course certified course on the abnormal uterine bleeding. Hearty congratulations to Dr. Lakshmi Shikande, who despite being past chair of ICOG is taking so much dynamic role and the dedicated role as a convener of the program, and our co-convener, Dr. Shashi Bhasle, Dr. Shobha and Dr. Meeta, all very, very good and the close friend, and we know they are like a constant involvement in the knowledge sharing and the academics. Yesterday, we had a great session on the basics of abnormal uterine bleeding. And as abnormal uterine bleeding, it is something we can say the dal roti or the bread and butter of any gynecologist, because it is the bleeding which actually troubles whenever it gets abnormal, right from the age of menarche to the postmenopausal bleeding. And as a gynecologist, we have to be very, very intricate and in-depth knowledge in hormones, in imaging, in understanding people's psychology and the numerous way of dealing that. So today, why we need more and more such expert faculties who have the experience and the knowledge, because maybe 20 or 30 years ago, the things were simple because we had very few options and people have very few demands. But today we have a lot of options. Many things suddenly come, suddenly go, and many things always they stay with us. And what are the surgical options? What are the medical options? What are the people's expectation? And what is the people's finance? So these are all issues which even a simple case of abnormal uterine bleeding comes to us, and we, with the FOGSI, with the ICOG, we have recognized that saving the uterus is something very, very important role, not only for the immediate fertility, but the long-term health goals. So we welcome all the esteemed faculties, and it is great pleasure, Dr. Lakshmi, Shashi, Shobha, that you have involved such a young faculty, or I have become senior. I see Indranil, Apurva, Archana. So these are I think they are very junior and they are very like a dynamic worker in the FOGSI and ICOG. Then Divya from Varanasi, Bharti Dhure Patel, and Ashok Kumar Todani. Yes, very, very senior people. And the panel will be moderated on a real case-based situation by Dr. Komal and Dr. Madan. And we have great expert medico-legal Dr. MC Patel and Ashish, a thorough teacher who makes always education very, very joyful. So hearty thanks and all the chairperson and all the panels who will add to our program, and we wish you a very happy learning and a very clear, concise clinical practice for the benefit of our women. Thank you very much. Thank you, Dr. Lakshmi, and all the co-convener for this opportunity. Thank you very much.
Thank you. Thank you, dear Sadhna, for your pearls of wisdom. Nilima, please share your CV slides from your side. Yeah, Ashok, whenever he joins, we will have his remarks. Next, Dr. Sheila Mani has already said. Yeah, next. Yes, so friends, I would like to just read the instructions for all the participants. Please pay attention that attendance for all 3 days is compulsory. The MCQ link will be shared in the chat box. We will also share the QR code, so please pay attention. And those who have attended all 3 day course, given exam on all 3 days, and has scored 50% marks on all the days, they only will be given the certificate of attendance. This certificate will be emailed to you within 1 month. Please note that this online course certificate is just an acknowledgement of attendance. Practice depends on skill and experience, which we do not certify. So we do not endorse any skills of the attendees. The videos, if any, will be put on ICOG website in due course. And for course material and the reading material, you may communicate with the course coordinators. Next slide. So I would like to introduce the co-convener for day 2, that is none other than Dr. Shobha Gudi. We all know how passionate she is for conducting the courses. She is convener for so many courses, and now also she is the governing council member of ICOG. And Shobha, I think you are Kasoga secretary as well currently. Yes. So invite Dr. Shobha Gudi to take over from here to conduct the scientific proceedings. Yes, Shobha. Shobha?
Yeah, I'm here. I'm here. I'm here. Yeah. Slight problem with my, yeah. So thank you very much, Lakshmi, for involving me on this AUB certification course. As Dr. Sadhna said, a much needed, initiative by ICOG. I think yesterday's session was superb, and I am required to give an overview. And what can I say? Every speaker has done fantastically well yesterday. And actually, 1 minute, not getting the D1. Yeah. So actually, it started with Dr. Jyoti Malik speaking on normal menstrual physiology and the pathophysiology of AUB, and her slides and her pictures were very descriptive and very detailed. A lot of learning happened then, as well as Dr. Alok Sharma's understanding of AUB, followed by Monica, as always, excellently deliberated on history and clinical examination. Very clinical presentation. It was very good. It was followed by the evaluation segment, and Aditi Rathore, Archana Basir, and Dr. Sarita Agrawal, all three did fantastically well. I must say that the laboratory precision with which Aditi told about the laboratory evaluation, and Dr. Archana Basir, wonderful imaging tips in AUB. So much for correlation of endometrium and the cycle, and between the different modalities of imaging, the way she compared and gave us the plus and minus of each modality. And of course, Sarita did extremely well with the histological evaluation and correlation with hysteroscopy. I was very impressed with the hysteroscopy information which she gave. But the icing on the cake, of course, was the wonderful panel by Supriya and Deepthi. Very much appreciated, and very dense participation by all the panelists on approach in a young woman with AUB. They did extremely well. None of them forgot the possibility of pregnancy and complication, and all of them spoke about how it is important to avoid surgical intervention and make it more medical and long-lasting benefit for the young girl. And the experts, Dr. Alka and of course Sudha Madam, who was VP for me, first VP when I was chairperson. It was so nice to see her yesterday. So all this has happened yesterday, and the post-test session also was conducted today. We have a lot more to look forward to, because today we will be learning about management. So, dear delegates, Now you get ready to know about the nuances of medicine. We're all good at, I think we do every day, but then there will be a lot of requirement to fine tune, and any updates which you will come to know today by Indranil, Apurva and Archana Dwivedi about the medical management, and the surgical interventions by Dr. Divya Agrawal on hysteroscopy, but Dr. Bharati Dore Patil. It is so wonderful to see Bharati again come to the forefront. We love you, Bharati. Welcome so much. Uterus sparing surgery, and then Dr. Ashok Kumar Todani on the final call for hysterectomy, when and which route, etc., and what counseling should go into it. But then I think today again we have to look forward to a very important panel discussion on medical versus surgical decision making, the final fine tuning which will happen for management calls, and Komal and Madan will be taking it forward. And I can see as experts our wonderful medico-legal expert MC Patel sir, the respected Patel sir, and also very dear brother to all of us, Dr. Ashish Kumar Mukhopadhyay. I so much appreciate sir for being here. In spite of his profound loss, we stand with him in his hour of grief. But sir, we really bow down to your presence because your commitment of teaching is so high. And of course, the panelists, you can see each one of them is a senior teacher. I'm hoping that each one of them will give valuable messages. So with that, I handed those over to the chairpersons. Nilima, I have to introduce the chairpersons.
Yes, Shobha.
Yeah, okay, Lakshmi. Briefly,
Very
I will
shortly,
introduce.
invite. Yeah,
So if,
yeah.
yeah, so most of them I know actually, all of them my dear friends. Hello? Hello?
Yes, ma'am. Please go ahead.
Yeah, so Dr. Rajeshri Katke, Dr. Rajesh, very senior teacher, very decorated teacher, I must say, recently won awards. We all appreciate her so much. She is, uh, yeah, associate member of RCOG as well, and has won several awards, as I said. And currently she is professor and head of the unit OBGYN and Grant Medical College. So welcome Rajeshri, and please take this forward once I finish with the other two chairpersons. Yes, the next, please. Yeah, yeah. And of course, it's such a pleasure to introduce Dr. K.S. Jayarani Kamraj, very, very lovely friend from Chennai. She's a senior consultant of reproductive medicine, infertility, and sexual medicine. I really admire her zeal for her area of expertise in center. And currently the chairperson in FOGSI for Say No to Violence Against Women. So I welcome you, Jairani. Next, please. Yeah, and then we have another valuable teacher from the South, Dr. Papa Dasari, alumni of JIPMAR, and 37 years of teaching experiences, several publications, and so many students of hers are in the practice arena today, and all of them remember her for her teachings. So, Dr. Papa, welcome to ICOG. So I request the chairpersons now to introduce the speakers one by one and take the session forward. Thank you.
Thank you, Shobha. A very special thanks to ICOG. I'm Dr. Jairani Kamraj here. It's a great honor and pleasure to be here to associate with ICOG, with all the stalwarts of galaxy of all the senior OBGYNs from all over the country to join together to spread the knowledge in a very beautiful way. A very special thanks to Sheila Mane Madam and all the senior faculties here. I have the great pleasure and honor to welcome and introduce Professor Indranil Datta, who is the professor and unit head of the OBGYN Durgapur, West Bengal. He's the director of this and senior consultant of JIC Nursing Home Kalyani and director Precision Healthcare Services. And he has a lot of organizational position holds, especially in the East Zone. He's the East Zonal Coordinator of Funda FOGSI, President in 23-24, Executive Member of Family Planning Committee, Public Awareness Committee, and he's the past President of KOHS of FOGSI. And he has a lot of awards and achievements. And he's the winner of the Shan Ratnam Young Gynecologist Award in Asia Oceania Federation in 2017. And he has been a very great academician with a lot of publications, more than 50 articles to his credit, and also a lot of editing, a lot of books for FOGSI, Focus in Drugs Update, and organized many national FOGSI conferences. And he has been an examiner for various university, MBBS, and other examinations. We welcome you, sir, for your deliberation on the talk on non-hormonal therapy with tranexamic acid, NICD, and evidence and protocols, which is the mainstay of the management of the AUB. Over to you, sir, for your deliberation.
Thank you, madam. Thank you for the introduction, and thank you. Special thanks to Lakshmi, madam, for inviting me to this all important session. And nice to see all my seniors. And I'm really happy that I am able to see all my seniors here. I'll just share my screen within 1 second. Yeah. Is it visible?
Yes, sir. Yes, sir.
Yeah. So thank you again. So I will not waste any time. We'll start and do a crisp revision of what we already know. So I'll be talking on the non-hormonal medical management of abnormal uterine bleeding. I'll be concentrating on the evidence-based protocols, the pharmacotherapy of the tranexamic acid and the NSAIDs, and with special reference from FIGO, FOGSI, and RCOG guidelines. So just to make it a bit crisp. So why non-hormonal therapy? Because many women are presenting with heavy menstrual bleeding. We know that prefer to avoid systemic hormonal side effect. They have a general idea that hormones may create some problem, and mood changes because it is associated with mood changes, weight gains, cycle suppressing hormones are there. It remains an absolute choice for women who are attempting to conceive, as it preserves the natural ovulation and monthly patterns of the reproductive cycles. The contraindications of the hormone are particularly the estrogen restrictions, the smoking in the patients aged over 35, or the active thromboembolic histories, cardiovascular safeguards, and localized targeting, and which provides immediate relief during the menstrual cycle with zero systemic hormonal modification. So how to select this patient, and particularly to do the taxonomy? The primary indications are the highest efficacy, which are observed in the non-structural causes like the endometrial causes of the AUB, the endometrial dysfunction, the ovulatory disorders, and the coagulopathies. These are the target areas of the indication which we can obviously start with this line of management which I am discussing today. As an interim relief, it can be used, and it is highly effective temporary medical relief in the structural etiologies, particularly in small leiomyomas, which are less than 3 centimeter or very early stage of adenomyosis, while the surgical schedules are finalized. So we can have an interim relief with these medications. What does FIGO say? So the consensus is recommends early first trials of the non-hormonals in all reproductive age group presenting with the chronic cyclic heavy bleeding of the benign origin. So I think we all follow that when they come to our OPD with some sort of abnormal uterine bleeding. We start with these medications like tranexamic acid just to control the bleeding for some time, and in meanwhile we can evaluate them further. Now, just going in a bit deep into what does happen in the molecular level. So, it basically causes the fibrolysis inhibition. Tranexamic acid is a synthetic lysine derivative that binds reversibly to the lysine binding domains of the plasminogen molecules. This blocks the alterations, the physical interaction between the plasminogen, the tissue type plasminogen activator, and the local structural fibrin matrices. And by preventing this plasmin generation, the tranexamic acid preserves the local uterine intravascular fibrin networks, thus decreasing the excessive blood loss during the menstrual cycle. That is the main thing which is happening there. So it actually helps in decreasing the blood supply with not much of other side effects related to the medication. So usually, if we want to give it for a long-term cyclical dose, we can give in an oral medication of 1 to 1.5 gram. We can go max up to 3 times daily during the active menstrual flow, and we can limit to a higher percentage. But we usually don't give so much in our day-to-day practice. But yes, we can actually give that up to 4 grams per day, limited strictly to 3 to 5 days of the consecutive days. And it can also act as an acute rescue protocol where you want to immediately control the heavy menstrual bleeding related to the abnormal uterine bleeding, and as an intravenous dose, that is 10 milligram per kg body weight, slowly via IV infusion, and repeat every 8 hours. The transition to the standard oral regimens, once it can be taken once the parameters hemodynamic stability has been achieved. And efficacy outcomes, there are grade A level 1 evidence which shows that it reduces the subjective and the objective menstrual blood loss by almost 50 to 40 to 50% from the baseline cycle, which is quite a lot. It will actually bring a lot of instant relief to the patient. Now, coming to the safety and the thrombosis myth, there is a myth that it will increase the venous thromboembolism, but multiple studies have shown that, and multiple clinical trials have shown that there is a 0% chance of increase in the venous thromboembolism. And particularly large prospective cohort evaluation and systemic database reviews have confirmed this in various studies, as we know that tranexamic acid has become the part of our routine medications in our day-to-day practice. But there is a mandatory renal dosage reduction, particularly since it is a primarily eliminated and unchanged by the kidney. The dose adjustment must occur for the creatinine clearance below 50 ml per minute, and contraindicated, particularly in cases of severe stage 4 or 5 renal failure. So these are the few places where we should be aware and alert. Coming to the another important drug which has also an important role to play in this non-hormonal type of management, that is the NSAIDs, and particularly the causing the prostaglandin cascade. So basically what occurs here is the cyclooxygenase blockade, where the excessive heavy menstrual bleeding is highly correlated with the elevated endometrial prostaglandins, particularly the PGE2 and the PGF2 alpha. The prostaglandin excess causes severe uterine vasodilation and down-regulates the localized spiral arteriolar vasoconstrictor responses during the shedding, and by competitively blocking the COX-1 and the 2 enzymes, this NSAID restores the endometrial vasoactive ratios, promoting vasoconstriction. So these two drugs play a very important role in our first line of management in current times, and sometimes they are given also in combinations. So if we go about the NSAID selection and the protocols, particularly if we talk about the mefenamic acid, it is given in the standard dose of 500 milligram orally, and timing can be tedious, starting from day 1 for 3 to 5 days, and it causes mean reduction of around 25 to 33% with strong clinical evidence. Hence, it has a very good role, and sometimes it is in combination with the tranexamic acid also, which is usually we prefer in cases of heavy menstrual bleeding. Naproxen 500 milligram loading, and then 250 to 500 milligram BD or TDS continue for 3 to 5 days. 25 to 30% reduction is there, similar to the above drug. And lastly, the ibuprofen, that is 400 to 600 milligram TDS, starting with the onset of the flow, and the reduction is around 20 to 28%. And the unique advantage which it has is it has a favorable gastric tolerance, highly accessible over the counter options. But usually the drug which is commonly which we are using is the tranexamic, and the combination with the NSAID, that is the mefenamic acid. So synergistic combination therapy, as I was telling you, co-prescribing the tranexamic acid and the mefenamic acid concurrently targets the dual complementary pathways, simultaneously maximizing the vascular clot stability while successfully suppressing the prostaglandin-induced uterine pain, which is a clinical consensus which is also declared in the FOGSI GCPR guidelines. So it actually, this co-prescribing plays a very important role, particularly as a first line medication, particularly where we don't know what is the cause of the abnormal uterine bleeding, and you want to buy some time just to identify the main cause. Irrespective of whatever the cause is, we can obviously start with this combination therapy. It is perfect for the dysmenorrhea patients, excellent therapy choice for the patients where the pain is a major driving clinical symptom. So once the pain is reduced, automatically the patient compliance is much better. And there is a gastric safety. Coming sometimes we have to add the PPI if we are adding that tranexamic acid, because it may sometimes lead to some issues in some patients. But if we are using ibuprofen related medication, it plays a good role in gastric safety, but it depends on patient to patient basis. So as we can see, if we can compare, so combination therapy of the tranexamic acid and the NSAID has the mean menstrual blood loss of around 60%, which is quite significant. And compared to tranexamic acid, which alone 50%, and NSAID is around 28 to 33%, and compared to the placebo, which was around just 15%. So actually, these drugs play an important role. Now, what does the global clinical guideline say? So, NICE guideline says, which is very recent, says that recommend as first line strategy offers non like we should offer the non-hormonals when the hormonal routes are rejected or declined. Evidence are strong recommendation based on the high quality trials. Specific provisions are to use tranexamic acid and NSAID cyclically and cease treatment if there is no improvement after 3 cycles. So we can start the treatment and we can cease it if actually there is no help to the patient after 3 cycles. But in that time, obviously, we'll diagnose the major causes which is responsible. Now, what does FOGSI says? So FOGSI GCPR recommends the tranexamic acid and NSAID as a primary therapy for the cyclical endometrial bleeding, and it has a grade A level 1 evidence, strictly warns against use of NSAID in documented coagulopathies. RCOG Green Top says non-hormonal methods are highly recommended if fertility preservation is prioritized and evidence is grade A, and stresses the outpatient workups before moving into invasive surgical intervention. So it can be used as an interim drug also. So if we look into the brief treatment algorithm and timeline, clinical workup, particularly after controlling the bleeding, we can perform a diagnostic pelvic TVS to exclude large fibroids which are more than 3 centimeters or atypical hyperplasia, because in these cases this combination may not work as how we intend to do. We can start them on a trial. Obviously, we can give them the medication to get at least 50% reduction of their trouble what they're facing now. Initiate the cyclical therapy with oral tranexamic acid 1 gram TDS max and mefenamic acid 500 milligram TDS on day 1. Check for the response after few days. Assess the clinical response, the pain level, and the quality of life after complete 3 bleeding cycles. At least 3 cycles should be enough. So you have to assure the patient that 3 cycles they have to continue, just to give you an idea whether the medication is working for them. If it doesn't work, then
your time is up.
yeah, just I'm summarizing. It's over. So tranexamic acid, the absolute prohibitions are thromboembolic disease, aneurysmal risk, ocular status, particularly severe acquired color deficiencies, and NSAID absolute prohibitions are gastric mucosa risk, coagulopathies, and renal failures. So first line choice is tranexamic acid monotherapy, and specific protocol of tranexamic acid is strongly recommended. The absolute NSAID warning has to be kept in mind. Hematological sync has to be there between the other choices also. So thus, just to summarize, the clinical non-hormonal therapy with tranexamic acid and NSAID present a cheap, low risk and fertility preserving options. Consistent patient screening and adherence to the FOGSI and NICE protocols ensure high quality patient centered care. Thank you.
I think, thank you, Indranil, for such a wonderful presentation.
Thank you, madam.
And it's very rightly mentioned that we should not start directly on the hormones. There has to be some space to start the hormones and evaluate clinically and with the investigations and all. So, and it's very good in cases of the puberty menorrhagias or reproductive age, where they will have they comes with occasionally passing of the clots and all those things. And we can investigate more efficiently in a perimenopausal age group, where we should not be on the only the such non-hormonal things or hormonal things. Diagnosis will be very important to manage such cases in that.
very nicely presented and
Thank you.
given
Thank you, ma'am.
up to the mark.
Thank you. Indranil, please answer all the questions in the
Yeah,
chat
yeah, I'm
box
here.
before
I'm here.
leaving. And
I am here.
Dr.
Yes.
Papa Dasri, I request you to invite our next speaker. Archana, has Apurva joined or are you giving?
No, Apurva is here, madam.
Ma'am,
Apurva is here.
hello, ma'am.
Apurva,
Yes,
yeah.
ma'am, I have joined. Yeah,
Dr. Papa, please introduce Dr. Apurva
this
Kumar
is
Datta.
old CV.
I can see. Yeah.
Congratulate Dr. Indranil for the nice presentation.
Thank you, madam.
Just I want to add one thing. There should be a clear-cut duration of therapy for this medical management. You have to find out the cause. Like I had a patient who was taking, she was in Dubai. They had put her almost 1 year of tranexamic acid, but thrombosis. So it should not be given for more than
3 cycles.
I mentioned
Yes,
3
yes,
cycles
he
is
said
enough.
more than 3 cycles here, and you have to evaluate the case also.
Kept on taking for I think almost 1 year. And people are refusing to do her hysterectomy because she is at high risk. Then she landed up here with me. So we should emphasize that duration of therapy is very, very important. We should not harm the patient. So I welcome the next speaker. Can I have the slide? Can I have the slide?
Ma'am, we are actually running late, so we can go. Thank you
Okay.
so much, ma'am.
Yes.
Okay.
Okay, fine.
Fine. Go ahead. Thank you.
Yeah. Okay. Thank you so much, Papa ma'am. And I am Dr. Apur Kumar Datta. That was my old CV, and currently I am the chairperson of Sexual Medicine Committee. And at the outset, I would like to thanks to Lakshmi ma'am, to Sila Mane madam, and all the ICOG for giving me this opportunity, and for because we always have a confusion that what investigation which show, what treatment is available. And so I really congratulate ICOG for bringing such a common, such a simple, yet such a difficult topic, that is the AUB. So, and my job is done really easy by my senior and my friend, Dr. Indranil Datta. So I will be dealing with the hormonal therapy. So my PPT is, yeah, it visible?
Yes, sir.
Yes, yes, it's visible. Please.
No. Okay. So what is the goal of the hormonal therapy in AUB? So the goal is, in acute AOB, it is the arrest of the heavy bleeding rapidly, to prevent the hemodynamic instability and avoid any emergencies, whether it's a surgical emergency or needing for the blood transfusion, etc. Or what is the goal of therapy in the chronic AOB? So chronic AOB, to regulate the menstrual cycle, to reduce the volume of the menstrual blood loss, to prevent the endometrial hyperplasia. Now, why there is endometrial hyperplasia? Well, because it is the risk factor for the atypical cellular atypia and can lead to the endometrial cancer. And also it's a help in improving the quality of life, and it also help in correct the iron deficiency anemia. What is if there is, because a lots of hormonal therapy also containing the irons, which is available, freely available by the government. So it's also help indirectly to improve the iron deficiency anemia. So now coming, what are the options available? So we have the COCs, that is the combined oral contraceptive pills. We have progesterones, either in the form of oral or injectable. We have the levonorgestrel release IUCDs, that is the Mirena or LNG IUCs. And we have a GnRH agonist and antagonist, as well as the last but not the least, we have the selective progesterone receptor modulator, that is SPOMS. So these are the hormones which are available today. So we will take it in a very crisp, because the time is very limited. We will take very crisply and take it one by one. So now OCPs, we all know, or the COCs, we all know, estrogen stabilize the endometrium, whereas the progestin control the proliferation and it reduce the atrophy. So it reduces the blood flow during the menstrual cycle. So what is the regime we have available? So we have for the chronic, we have a standard regimes of the 21/7, or we can have the extended or the continuous regime to eliminate the withdrawal bleeding entirely. For example, it is the seasonally we have, and where we are giving like 84 tablets regularly without a single break. So we have the standard cyclic, or we have the extended or continuous regime, or we have the acute regime. So it has a taper high dose, that is the monophagic COCs, that is the thrice daily for 2 to 3 days, and then twice, and then daily. So these are the different type of COCs. Now, how efficacy is there? Absolutely, it is effective, and it reduces the menstrual blood loss by approximately 50% of cases. And the first line of therapy is our COCs, provided it is not contraindicated. So that I will take in the later stage. So this all about the COCs. Now coming to the progesterone therapy. So we have a two type of, we have a oral, we have a injectable. So oral, we have a cyclic oral progesterone. We have a two, the compound is available with us. That is the medroxyprogesterone acetate, 10 mg milligram. Starting dose is 10 mg milligram, or we have a norethistron. It is the 5 milligram. So now many times, the people are asking me, even the some doctors are asking me, which is better? So according to me, and I couldn't find anywhere, these both are equally effective, and it's not that one is better than the other. Both are equally effective. So it induce the primarily for the AUBO. What the palm coin classification yesterday, they have a detail about the palm coin classification. I'm not going to drill into that, but AUB ovarian, it is the primary therapy for those type of patients. It can be given. There is a two type of, either we have just in the proliferative phase. For example, starting from day 12 or day 14 of the cycle, and continuously for 14 days per month. So this is one thing, that cyclic oral progesterone. So again, we can have a continuous high dose of the progesterone. In that case, where there is a heavy menstrual bleeding, we start it from day 5, and we have to give continuously from 21 days. That is for the whole cycle. So these type of two regimes are available for the oral progesterone therapies. Now coming to the injectable therapy. So again, it is the depomedroxyprogesterone acetate, commonly known as the DIMPA. Again, it's a very good, and it's a very cheap. It's freely available in India, and it's also available freely by the government supply also. And what is the dose? The dose is 150 milligram IM every 12 weeks. That is every 3 months. And there is a high rate of amenorrhea by 1 year. So this is about the progesterone. Now coming to the complication. Actually, these are devoid of any major complications, and you can use effectively in almost in every patient. So this is the about the progestins. Now coming to the levonorgestrel releasing intrauterine system, that is LNG-IUS. So it is the gold standard for the chronic AOB. But mind it, usually where we are using it, where the uterine contour is maintained, means there is no structural deformity in the uterus. In those cases, it is very much effective. What is the mechanism? The mechanism is, it is the local release of the levonorgestrel result in the profound endometrial suppression and profound atrophy. So it reduces the menstrual blood by almost 70 to 90% within the 6 months. The advantage, it's a high compliances, it's provide long-term contraceptive, and those especially who doesn't want kids, who doesn't want baby now, this is the ideal one. And it's also avoid any systemic hepatic first pass effect. So there's no systemic side effects. So disadvantage is the instrumental bleeding and the breast tenderness. So whenever I am using the levonorgestrel, you have to, educate your patient. You have to counsel your patient that is starting 2 to 3 months of there may be intermenstrual or there may be spotting can be done, and it will be, subside by their own. Or if they are very much anxious, and you can give the Trenexa, or you can give the norethistron if they are very much anxious about their periods. So this is from the starting 2 to 3 months, and when it settle down, then it will be effective for the 6 months. So this is all about the LNG IUS. The next is that is GnRH analog and the newer modulators. Now, what is GnRH analog or agonist? We all know another leuprolide and goserelin. Leuprolide, we gynecologists are using like anything, and it create a temporary menopausal and a medical menopause via the down regulation. So it is highly effective at inducing the amenorrhea. It's help also to shrinkage of the fibroids. It's if it is small. It's also help in the adenomyosis. It's also help somewhat in the endometriosis. So this is really a very good, really very good. But the limitation is it can be used up to limited to the 6 month of use because of the bone mineral density loss. So we have to use the add-back therapy in this type of patients, or else there will be bone density is very less, and the people is coming with all the hot flashes, all the menopausal symptoms and the low backache and back pain. So this is about the GnRH analog. So nowadays, every day, even today, I am sitting from the morning in my OPD, and 2 to 3 pharma companies are coming and they are saying this GnRH antagonist, elagolix, rolagolix, and what? And they are saying it is the gold standard, it is nothing. Please don't be, carried out with this. Yes, we can use it, but it should be judiciously. So the advantage of the GnRH antagonist is its immediate suppression without the initial flare-up effect. So the side effect of the GnRH agonist is actually not there. So it is useful for the fibroid related bleeding. It's useful for the dysmenorrhea and due to the endometriosis, etc. But mind it, what I am using this elagolix probably for last 1.5 years, it has no effect in case of adenomyosis. So it can be, it can reduces the bleeding of the adenomyosis, but it will not reverse the progression of the disease. So it will cause only one thing in adenomyosis, that is the bone loss. So again, we have to be very genuinely use this type of molecules. Sorry. And we have to categorize that which patient should get what the thing. So this is what about the GnRH antagonist. So this is the clinical algorithm. When there is a heavy menstrual bleeding, patient is stable, then high dose of IV estrogen or multiple dose of the oral COCs can be given. Alternatively, or the second option is the oral tranexamic acid, that is the Trenexa. For the chronic anovulatory, that is the LNG IUS or the cyclic COCs are really an ideal one, provided its COCs are not contraindicated and patient doesn't want the pregnancy now. And the alternative is the cyclic progesterone. For the structural problems, if there is not much, then we have to work out in this patient, and in that case, definitely GnRH analogs and GnRH IUS can be given, or we have a high dose of continuous estrogen. Now, the estrogen is contraindicated and it must be screened for the history of the cardiovascular symptoms, stroke, severe hypertension, smoking, overage, and active liver disease. And mind it, it's not like that the patients are coming and you are just giving them the hormonal therapy. Rule out any endometrial hyperplasia or malignancy in a high-risk patient. Where is the high-risk patient? When there is the age is 45 years or even younger, but having a risk factor like the obesities or OCPs before starting the long-term hormonal therapy. So
Sir,
what
time
is the
is up.
conclusion? Medical management. Yes, that's ma'am. Last slide. And a medical management, especially the hormonal therapy, is the preferred primary approach for the most cases of non-structural AOBs. And definitely we can reduce the burden of the hysterectomy by judiciously using of the OCPs. The LNG IUS
Sure.
greatest reduction in the long-term menstrual blood loss among the hormonal therapies. Therapy must be individualized based on the patient contraceptive need, underlying etiology, and the contraindications. That's all for my side. Thank you so much.
Well done, Apurva. And please answer all the queries in the chat box before leaving.
Absolutely. Absolutely. Absolutely.
Uh,
Thank you so much, ma'am, for giving the opportunity. And thank you so much to all the, chairperson. Jarani madam is there. She is like my elder sister. Thank you, ma'am. And Deshi Papa ma'am is there. Rajshri ma'am is there. Thank you so much. Thank you so much. Thank you, ma'am.
Only one message is very important in a reproductive age group. It's okay. But in a perimenopausal age group, don't start the hormones just like that. If there is endometrial hyperplasia, the gold standard is hysteroscopy and hysteroscopic biopsy or DNC. We have diagnosed many of the C endometrium because most of the time, what even Papa ma'am has also said that giving tranexia hormones, and they do come to with the C endometrium extending to the endocervical canal. So diagnosis is very, very, very important. Dating of the endometrium or the endometrial sampling is very important if you want to keep it on the prolonged hormonal therapy.
Thank you. Thank you. Dr.
Yes,
Papa, would you like to invite Dr. Archana?
Yes,
Please
yes.
share her screen. Dr. Papa Dasri, please, you invite her and you can conclude the session as well. Yeah.
Yeah, it's a great pleasure inviting
Dr. Archana Dwivedi.
Dr. Archana Dwivedi, who is the founder president of MSP and also National Website Committee member IMS and past president of BOGS, and she has lot of credits in her career. We welcome you, ma'am, and lots of awards also.
Thank you, Papa ma'am. It's a pleasure to be with all of you. Thank you, Lakshmi ma'am and team ICOG for giving me this opportunity. And I think Apurva has done the job. Can you see my slides, please?
Not yet. It's loading it. Yeah. Yes.
Can you see it now, ma'am? Okay.
Yes.
Thank you so much, ma'am, for the opportunity, and thank you, chairpersons. I will be restricting my talk AUB, GNRS analogs, and SPRMs. We'll talk about the latest evidences, and we know discussed yesterday a lot of things about palm coin classification, but we need to know that up to 1 in 3 women experience AUB in their lifetime, and most commonly when they are at menarchal stage or the perimenopausal stage. The parameters are affected the regularity, duration, volume, and frequency. And the normal cycles we range from 24 to 38 days, frequency 2 to 7 days, duration 5 to 6 days, and 80 ml blood loss. That is the basic thing which I like to start with. Now, talking about the GnRH analogs, which is my main topic, it's a short peptide analog of GnRH that causes profound inhibition of the estrogen and androgen synthesis, and are used predominantly as androgen deprivation therapy of advanced prostate cancer. But some of these agents have been used for the benign condition responsive to hormonal inhibition, such as endometriosis, uterine fibroid, precocious puberty, and infertility. We have GnRH analogs in under 2 headings: agonist and antagonist. Agonists have been found to be very much more potent and sustainable options in action. That the native decapeptide has been used extensively in modulation of sex hormone synthesis, which cause initial surge and then downregulation. Whereas the analog antagonist act in somewhat different manner in that it is an antagonist of the gonadotropin receptors in the pituitary and inhibit the LH-FSH synthesis and release directly without an initial surge, and that is a typical of the agonist quality. So what do you understand by the initial stimulation? The GnRH agonist, there's a flare response because of the release of the gonadotropins, which are already produced and stored in the pituitary. And indeed, this flare is greatest in the early follicular phase, where GnRH and estradiol have combined to create the large reserve pool of gonadotropins. But after a few weeks followed by pituitary downregulation, this produces a hypoestrogenic stage, which reduces the fibroid size and also the menstrual loss, the downregulation period. This hypogonadal state produced by GnRH agonist has been often dubbed as pseudomenopause or pediculohysterectomy, as described by Apurva previously. But the benefits is that there's decreased menstrual bleeding, reduce of the fibroid volume by almost 30 to 60%, which is ultimately going to improve the preoperative hemoglobin levels and is used as a bridge to surgery or menopause. But there are limitations to it, which causes hot flushes, vaginal dryness, mood changes, bone mineral density loss is there after the prolonged use, and generally limited to 3 to 6 months unless add-back therapy is used. Whereas the antagonist, the advantage is that rapid suppression is there. There is no flare effect, effective reduction in heavy menstrual bleeding. It can be orally given and can be combined with add-back therapy for a long-term use. Current role increasingly used for fibroid-associated heavy menstrual bleeding, and it is emerging as an alternative of GnRH agonist. So what are GnRH antagonists offered in our kitty in 24-25? We have seen all these molecules coming up: elagolix, relugolix, linacolix. Elagolix, the dose is 300 milligram BD, 150 milligram OD, which requires add-back therapy. And evidence is that it is FDA approved for AUB leiomyoma for less than 24 months of use. Whereas relugolix, the dose is 40 milligram, and add-back therapy estrogen and neta is like progesterone can be used. And evidence says, according to the European Medical Agency, it is approved by FDA also. Single daily tablet will it also compliant to the patient because adherence of therapy is important. Then linzagolix, which is still not in our market, it is also AMA approved, which is dose dependent and also causes the estrogen suppression. So meta-analysis says that there is a reduction of the fibroid volume around 27%, and also there is a significant bleeding control if we give it with the adherence of the protocol. There was a question in the chat box. The elagolix age is from 18 to 49 years to be given to the patient. Coming to the GnRH analogs, agonist versus antagonist. Agonist, the agents we know, the initial mechanism is initial flare, pituitary desensitization occurs, and then is a hypoestrogenic phase is there, hypogonadic phase is there. So key use is basically for the preoperative fibroid reduction, anemia correction, and pre-surgical thinning before the hysteroscopy can be offered. The flare effect, initial worsening the symptoms 1 to 2 weeks, but then gradually it improves. Bone loss limits its use to 3 to 6 months without add-back therapy. Whereas antagonist, which is the new molecule inside, has advantage of no flare effect, rapid onset of action, and the oral administration, it is reversible in action and FDA EMA approved for AUBL. The important thing is that it maintains the estrogen flow to protect the bone and reduces the vasomotor symptoms simultaneously. So a good option available. A little word about the add-back therapy, rationale and practice, what we should be doing when we are giving such molecules. Add-back therapy is essential because GnRH-induced hypoestrogenism causes bone mineral density loss. It is more than 3% over 6 months of use. Vasomotor symptoms are there, and genitourinary atrophy has been reported. So add-back principle is based on low estrogen flow, that is E2 or 1 milligram, protects against the bone loss and menopausal symptoms without losing its therapeutic efficacy of the GnRH molecule. So standard regime, as you said, we have to give a postmenopausal add-back estrogen along with the progesterone so that the things are taken care of. The duration and monitoring when we give the GnRH agonist without add-back, maximum 3 to 6 months. Primarily, as I hammered, that is pre-surgical use is important, but extended use is possible up to 12 months if you're giving add-back therapy. The oral antagonist and add-back therapy, which is already approved, like elagolix, can be given up to the period of 24 months. And still the trials are going on relugolix and linzagolix, which is not available. But monitoring should be done by DEXA scan, bone density, lipid profile, symptoms every 6 months of the prolonged use of these molecules, which is very, very important. Coming to the text part which has been offered, that is selective progesterone receptor modulators. There are lots of benefits now because there is a rapid control of heavy menstrual bleeding. There is reduction in the fibroid volume, preservation of estrogen level, which is a very important aspect of sperms, SPRMs, and resulting in few menopausal symptoms. But the limitations, again, concerns regarding the rare but severe liver injury. Its use is restricted or suspended in many countries because of this. And in many countries, required liver function monitoring where it is approved for prescription. So selective progesterone receptor modulators, the mechanism is that synthetic steroids which act on progesterone receptors, and the mixed agonist-antagonist tissue selective activity is there, causes decrease in fibroid cell proliferation, apoptosis is increased, and endometrial proliferation is decreased. So without inducing full hypoestrogenism, it is acting on the target site. The available options are mifepristone, which was the first SPRM, which reduces the fibroid size and bleeding, approved by ACN Cushing's, off-label for fibroids. We have rampantly used and seen the effect over the period of 3 months. If you give, there's a significant reduction in size. The other is ulipristal acetate, which is again commonly used. The proven efficacy is for the pre-surgical and intermittent use. Hepatotoxicity concern leads to was the cause of its withdrawal. So 5 milligram 3 months course can be offered to our patient with a significant reduction in the fibroid size. Other molecules are velapresan and Asor, which is still not available. Development has been halted because of hepatotoxicity and is not available for the clinical use. So if we see over the PR modulator associated endometrial changes, the class effect is benign, reversible, requires endometrial biopsy if bleeding occurs. Even after the treatment, as ma'am rightly said, you should always rule out the cancer possibilities in such patients. Hysteroscopy is the gold standard. You should always offer our patient if it's the bleeding is not stopping. So GnRH analog disease-specific indications to be tabulized is AUBL, leiomyoma, where oral GnRH antagonist, any of them, along with the add-back therapy plus minus, can be offered as a first-line treatment. Agonist pre-op used to shrink the fibroids, correct the anemia before the hysteroscopy or the operative procedure. Relugolix, in the real world, hemoglobin rise is seen, almost 25% reduction in the uterine volume is seen, and 26%, which was a 2024 study. The meta-analysis of 2025 says that the fibroid volume is shrink to almost 25 to 27%, control over the placebo which was given. Talking about the adenomyotic adenomyosis AUBA, GnRH agonists reduce adenomyosis volume and pains, symptom recurrence post-stoppage also can be seen. Sequential therapy, GnRH agonists for 3 to 6 months, followed by Dynogest, improves the compliance more. Dynogest alone can cause AUB in some because of pseudoresidual bleeding, which is the common term used. GnRH pre-treatments, study was done in 2025, has been a good option to it. Extended interval GnRH agonist dosing under investigation, so can be prescribed with a caution. Pre-surgical use, pre-hysteroscopic resection, GnRH agonist, thin endometrium, reduces the operative time. New oral antagonist emerging as alternative, faster onset, there is no flare effect seen. And Cochrane data says agonist before hysterectomy shorten the surgery, reduce the blood loss. Anemia correction can be a good modality if you offer 3 months course of agonist or antagonist just before planning the myomectomy. It can be helpful. So comparing the root agonist, antagonist versus, this is a very important chart which I would like to highlight. The root, the onset of action, flare effect, estrogen level, bone risk, fibroid shrinkage, bleeding control, approved duration, and key safety and fertility preservation. If all these are considered into account, GnRH agonist can be given as subcutaneous IM injection. Flare effect are seen. And castrate level, hypoestrogenism does occur, bone risk is high. Fibroid shrinkage, you can see it is giving a good amount, like almost 35 to 60% compared to GnRH antagonist. But again, add-back therapy is one thing which is a problem here because bone loss, menopausal symptoms are there. Fertility preservation is possible in all 3 of the options which are available. SPRM's hepatotoxicity is a concern which is there. Though the bleeding control is almost 70 to 90%. Here in this case, only 3 months course will be a beneficial course. Lipid changes are seen in GnRH antagonist, whereas bone loss and menopausal symptoms stand when we give GnRH agonist. So flare effect is not present in GnRH antagonists and SPRMs, and the estrogen levels are near normal when we are giving SPRMs. But fibroid shrinkage is not a good option because variable studies have shown that there's a variable shrinkage available, and it is a recurrence which I've seen over a 3 months of trial. If you leave the patient, there's a rebound phenomena which has been seen. But bleeding control is a good option when we talk about the SPRMs. So,
sorry, ma'am, your
clinical-
time is up.
Yes, and this is the last slide only. So, clinical decision algorithm, you can AUB with suspected structural cause, exclude pregnancy, confirm by imaging, fibroid more than 3 centimeter, failed first line pre-surgery. GnRH antagonist setback therapy can be given. Consider SPRMs if antagonist is not tolerated or for fertility preservation. First line levonorgestrel tranexamic acid COCs can be given. Surgical myomectomy, hysterectomy, UAE ablation can be indicated. So other adjunct option we have already discussed with Dr. Apurva's lecture: medroxyprogesterone acetate, levonorgestrel, LNG-IUS, Tibolone, NSAID IUDs, mefenamic acid can be given. Tranexamic acid used very well prescribed by Dr. Indradil sir. So this is what is a good molecule, judicious use. These are my references where have been taken. I'll stop the sharing, but I think we have to be very judicious when we are prescribing hormones at any level of the, especially when menarche or near the perimenopause, because we have to justify the role. We have to weigh the risk versus benefits. So this is what I had to offer in the adjunct therapy. Thank you so much for patient hearing, and thank you, chairperson, especially Papa Ma'am Jeradi, who's a very good friend, and Rajshri Ma'am. Thank you for the inputs you have been given all throughout. Thank you so much. Thank you, Lakshmi Ma'am.
Thank you, Archana, and please answer all the queries in the short chat box. Yes, chairpersons. Dr. Papadasri, you would like to comment?
Thank you, Dr. Archana. That is a very crisp presentation. You have given maximum information in minimum time, and your slides are very, very good. And just to conclude, you asked me to conclude now.
Hello.
Yes,
So,
yes, please.
Hello.
to conclude Dr. Archana's talk also, she has given the duration of therapy for these GnRH analogs antagonists, minimum 3 months, maximum 6 months. But I don't know, Elagolix 24 months it is given. I have not given for anybody because again, bone loss is the problem. So, medical management, I would say, to be given for a minimum of 3 months. Evaluate.
Elagolix, basically, after 3 months, you have to compulsorily add the add-back therapy.
Add-back therapy, yes.
Standalone Elagolix is
And,
not recommended beyond 3 months. And even in those patients, I am routinely using
Hello.
Elagolix.
Sir,
Some
एक एक
patients,
मिनट
they
करके,
do
एक
have
एक मिनट.
hypoestrogenic side effects even after 1 month or 1.5 months of therapy. So prolonged use is definitely recommended with add-back therapy.
Can I add one thing in that? I feel
Yes,
in
Rajeshri,
cases,
please.
I feel in cases of the AUB, how much you should pull with the new advanced, GnRH analogs and antagonists. It has to be decided one. That is the most
Yes.
important thing. Means, treatment of AUB with so much of the bone loss. So where to stop? That is the most important thing. What I feel means you should
Yeah, I
see
completely
pros and
agree.
cons, and
Completely
then
agree.
you can give the other options of treatment, like even like endometrial sections or other things are there, hormonals and all. But it was a very crispy and very nice presentation, Dr. Archana, because that may
Thank
be
you.
the future, and it will be the good options, because number of patients we are seeing with the AUB after diagnosing the other causes of the malignancy in that. Thank you very much, Dr. Lakshmi ma'am. Thank you,
Thank
Shobha
you.
ma'am, for those kind words. Thank you, Sheila Mane ma'am, Pratik sir, Sadhna Desai ma'am, and all of them. Thank you. Thank you very much.
Jayrani,
I
are
think
you
you
here?
meant
You want
Sadhana
to say
Gupta, not
something
Sadhana
before?
Desai.
नहीं
Yeah,
नहीं, साधना
Sadhana
गुप्ता ही
Gupta,
बोला
yes,
मैंने.
ma'am.
साधना मैम बोला.
I think Shobha
Acha.
madam wanted to make.
Jayrani, are you here? Because we are already behind schedule. If she's not here, I would like to invite Pratik. Pratik, you want to address the audience as a secretary ICOG? You are most welcome.
No, I think we have had an excellent first day's proceedings, which was covered beautifully by all the faculty. We are proceeding with full steam ahead. On the second day, I look forward to hearing more and more evidence-based talks and the panel. Congratulations to the conveners and all the esteemed faculty. Thank you very much for sharing your precious time and, of course, your knowledge with us. Please proceed.
Thank you. Shobha, let's move ahead with the second session.
Yeah, thank you, Lakshmi. Let me move ahead. I must say that
Archana, please answer all the queries in the chat box before going.
Yes,
Huh?
yes, ma'am, I'm
Yeah.
doing that only. Thank you.
Yeah,
Thank you.
yeah. So all speakers are requested to actively reply the questions just as they pop up.
Yes.
Because in a webinar, it's very difficult to keep track, and the one who has asked the question will be immediately looking for answers. So please do that.
Yes.
Thank you very much. And also this session which just got concluded, very, very high relevance, because gynecology has already become very, very medical and less surgical. But then there are some women who will not respond to therapy come what may, and for them we have the next session of surgical management. So I invite the chairpersons, Dr. Durgadas Asrana, Dr. Renu Yadav, and Dr. Aruna Kumari Kode. Okay, please share the CVs. Yeah. Yes. So it's my pleasure to introduce to the house Dr. Renu Yadav. 1 minute. Consultant, Sharabati Surgical and Maternity Home at Haryana. And Madam has been a member of the Indian Medical Association also. Her special interest, she is a past secretary of Rewari OB-GYN Society. And she has special interest in vaginal approach to hysterectomy as well as in endoscopy and high-risk pregnancy. To welcome Dr. Renu Yadav. Next, please.
Thank you.
Yeah, so then we have, of course, I'm not getting the name of this.
Dr. Aruna Kumari Kode. Koda.
Yes, Dr. Koda. Dr. Koda, because the name is not featuring there.
Yeah, name is not there.
Not featuring. So from postgraduate from PGI Chandigarh and ex-associate professor GSL Medical College Rajamundry. She's a senior consultant at Harsha Hospitals Rajamundry at present, and I'm sure she's been waiting to welcome us for the the FOGSI at Rajamundry, which is to happen in September. So welcome, Dr. Koda. And then actually
we have Durgadas Asrana.
We have Dr.
No,
Durgadas Asrana.
Shobha, we have another chairperson, Dr. Durgadas.
Yes, I'm waiting for
He has forgotten to send his CV.
Then
he's a
I
very
can introduce.
active, very active member of FOGSI, and he is a great academician.
Shobha knows him
we
very well.
Yeah. Lakshmi, I was his secretary when he was president.
Okay. I thought he has not sent.
So I know both sides of the coin, and with Durgadas, there is only one side of the coin. There is only goodness on both the sides. Durgadas is, yes, he's synonymous with diligence. He's synonymous with dedication. I am very, very personally fond of him because he's such a transparent, open-hearted person and a very good academician also. He has been attached to Medical College in Tumkur, but mainly he has his own hospital. His year of presidency in Kasoga was very, very vibrant, and it was a pleasure to serve with him as secretary for me. And he conducted a very magnificent conference in Tumkur, which many FOGSians also had we had the pleasure of having many FOGSians also there, including the president-elect and many others. So with that, welcome Durgadas to you also. And of course, we are hoping that he will come and hold a
I am the first speaker, so please show my slide.
So I request the chairpersons to introduce Dr. Lakshmi Srikhande. She is the first speaker, and after that, the other two, Dr. Bharti may not be able to deliver her talk.
Yeah, she's traveling. She's not in the network, so she requested to exchange the talk. Yes.
So Divya and Dr. Ashok will follow Dr. Lakshmi.
Yes.
Thank you very much. Please take it forward.
Thank you, Dr. Shobha. Hello.
I think Dr. Redu, you are from two device.
You'll have to switch on the microphone on one device.
Hello.
Yeah, please go ahead.
Okay.
Thank you, Dr. Shobha. Thank you, Dr. Lakshmi, for inviting me to this very good session. And it gives me a great pleasure to invite Dr. Lakshmi Srikhande. And she has been the past president of ICOG. And now she is taking active part in this session of AUB. She has been a FOGSI representative to AOFOG, Asia Oceania Federation. and has been a FIGO committee member for climate changes and toxic environmental exposures. Vice President National ISOPAB from 2026 to 27, and she has been President ISOPAB Vidarbha chapter from
Yes.
2021, and Chairperson ICOG. Thank you, ma'am. I would like to invite you to give your deliberations. Thank you, ma'am.
Thank you. Thank you so much. So, friends, we have to mutually exchange because Dr. Bharti Dore Patil is traveling and she is not having any network. Pratik, are you here? So, can you see my slides? Am I audible?
Yes, ma'am. Audible, visible.
Yes.
Please go ahead.
So,
Yes,
thank you.
yes, very much.
So
Dr.
my
Lakshmi.
deliberation is on perimenopausal AUB. So I'm straightway going on the topic that the treatment of AUB in perimenopausal female depends on the diagnosis. Proper diagnosis is half work done. Treatment options must be selected based on your diagnosis, but first you have to rule out the pregnancy. Next, rule out malignancy. And third, don't forget to rule out non-compliance with the hormones. Then comes the etiological treatment. You have to decide whether you are dealing with the palm causes or you are dealing with the coin causes. If you are dealing with the palm cause, then in the P, hysteroscopic polypectomy is an effective and safe option. If it's single endometrial polyp, then just go ahead and perform hysteroscopic polypectomy. If there are multiple polyps, of course, whether it is single or multiple, you are sending them for histopathological evaluation. And if it turns out to be malignant, you have to manage them as AUBM, that is AUB malignancy. If it is adenomyosis, this can be controlled with suppressive therapy similar to those used for AUB without structural changes, such as combined contraceptive progestogens and GnRH analogs as well. So this is the algorithm. You can see if she is desirous for fertility and she is unwilling for immediate conception, LNG IUS is the best. If she is unwilling to use LNG IUS, then you can go ahead with GnRH agonist with add-back therapy. If she is not desirous of fertility, you can treat her with GnRH agonist with add-back therapy. And now we have GnRH antagonist in our armamentarium. Leiomyoma should be based depending on the number, location, and size of the leiomyoma as well as her future desire for conception. So best surgical approach is defined according to the proportion of submucous or intramural components. So accordingly, you can decide whether you want to go ahead with the hysteroscopic route or with the laparoscopic route. If palm, that is malignancy is there, then depending on the stage of the cancer, the gynecologist, that is you can perform a total hysterectomy or a radical hysterectomy. Now coming to the coin causes and how to manage them in perimenopausal age group. So first and foremost, we have to rule out malignancy, but at the same time, we don't have to panic and no, we don't have to create phobia in the patient's mind. So these are the indications for endometrial biopsy. If she is more than 40 years and if she is less than 40 years, but she is having high risk factors for CA endometrium, that is she is obese, endometrial thickness is more than 12 millimeter, malignancy using tamoxifen, or she is having breast cancer, she had late menopause, or she is having hereditary non-polyposis colorectal cancer, or she is having AUB which is not responding to medical treatment. Hysteroscopy is not recommended in all the patients to rule out malignancy. These are the guidelines which tells us that in which cases hysteroscopy is necessary. So this is an outpatient where outpatient endometrial sampling fails or is non-diagnostic, or when endometrial hyperplasia is diagnosed within a polyp or other discrete focal lesion. In these cases, you can go ahead and do the hysteroscopy. We are having various options to manage coin causes. It can be hormonal and non-hormonal. Hormonal, we have CNC, COC, LNG has been discussed since morning. Don't forget that we have diosmin in our armamentarium as well. Not all causes of AUB is because of hormonal imbalance. Somewhere capillary fragility is also responsible. So in these cases, you can use diosmin 900 milligram daily from 15th day of the cycle until end of menstruation itself for 3 consecutive cycles. Ormeloxifene also can be used in perimenopausal AUB. It's very safe. It does not exhibit progestational, androgenic, or anti-androgenic properties. It does not cause cystic enlargement of the ovaries and it does not cause increased endometrial thickness. The dose is twice or once weekly, that is 60 milligram tablet twice a day for 12 weeks, followed by 1 tablet of 60 milligram once a week for another 12 weeks. It reduces menstrual bleeding by 60 to 70%. Of course, it is contraindicated in breastfeeding, PCOD, chronic liver disease, jaundice, chronic renal disease, tuberculosis, cervical dysplasia, and chronic cervicitis. Now, the main focus of the talk in perimenopausal AUB is endometrial hyperplasia. I am sure everyone knows that now we are following the new WHO classification of endometrial hyperplasia, which came into existence in 2014. Hereby, we are having only 2 categories, that is hyperplasia without atypia, and we are having atypical hyperplasia. So if you have done endometrial biopsy and your report turns out to be endometrial hyperplasia without atypia, don't panic. Many gynecologists, the moment they read the word hyperplasia, they fear that this patient will get carcinoma endometrium. So pay attention to this slide. What is the risk of carcinoma endometrium in this type of endometrial hyperplasia? The cumulative 20-year progression risk among women with endometrial hyperplasia without atypia is less than 5%. Most cases will regress on its own. However, if you are adding progesterone in these cases, then the regression rate increases from 89 to 96%. Importantly, you have to treat the reversible risk factors for this kind of endometrial hyperplasia, that is obesity and HRT should be identified and corrected if possible. So what is the treatment? Of course, LNG IUS is recommended as first line therapy. If it is contraindicated or patient is unwilling to use it, then oral continuous. We don't give cyclic progesterone. You have to give continuous progesterone. Medroxyprogesterone 10 to 20 milligram per day, norethistone 10 to 15 milligram per day. In which cases you will go ahead and offer surgical treatment in endometrial hyperplasia without atypia. Hysterectomy is only indicated in this kind of endometrial hyperplasia if there is no regression after 12 months of treatment, who progress to atypical hyperplasia, who has relapse after treatment completion, who has persistent abnormal bleeding, and those who decline to comply with the treatment and surveillance. But don't try to fit in all your cases of hysterectomy in the last indication. How you will follow up these cases? According to all the guidelines, you have to perform OPD based endometrial biopsy every 6 months. If your report comes as endometrial hyperplasia with atypia, then yes, the risk of malignancy is high. In these cases, total hysterectomy is offered as the first line of treatment. You can go ahead and perform bilateral salpingo oophorectomy, whereas for premenopausal women, you should go ahead with bilateral salpingectomy and try to preserve the ovaries in these cases. If your patient wishes to have a fertility, desirous for pregnancy, then you can refer her to a fertility specialist after at least 1 negative endometrial sampling according to the RCOG guidelines. If this perimenopausal woman is on HRT, then you have to review the indication for HRT carefully. And for those women who wish to continue, they should be advised to have continuous progestogen such as LNG-IUS or a continuous combined HRT preparation. If this is a woman who has been managed according to the old classification system of endometrial hyperplasia, then you have to counsel your patient about the recent evidence and treatment recommendations. Can you prevent endometrial hyperplasia? It is unlikely, but you have to counsel her about her weight management, and losing weight will definitely help. And of course, PCOS should be kept in control. So the surgical treatment for AUB without structural lesion, you can offer her endometrial ablation in uterus preserving surgery, or the last resort is hysterectomy. The liberal use of hysterectomy to treat AUB in perimenopause reflects the failure to identify a cause of AUB which is present in most women. And when you are doing the diagnosis according to palm coin classification, for most women, you will be able to find an effective non-surgical approach or uterus-sparing surgical approach in most of the women. So the inadequate evaluation and fair trial to medical management, this leads to more and more number of hysterectomies in this age group. Most of the gynecologists say, no, we are only removing the uterus, but we are preserving the ovaries. But friends, just look at this slide. Even if you preserve the ovaries, in due course of time, these ovaries, they stop functioning. So ultimately, your patient lands up with premature menopause, and we should be able to counsel our patients about the life after hysterectomy, that she will have vasomotor symptoms, it will have adverse effect on her sex life, and she will have psychological symptoms as well. Plus, she will have more risk of coronary artery disease. Don't forget the medico-legal thing as well. I have heard many colleagues saying that, oh, I have done thousands of hysterectomies and I can chop off the uterus in 20 minutes. Agreed? But what if this only case lands up with some complication? These patients use you. Remember, you have to justify each and every case of hysterectomy. I don't know how many of you have undergone or read this article. This is the Government of India guidelines to prevent the unnecessary hysterectomies. This was released in April 2023. You just type this on Google and you will get this document. This is a 49-page document where government is telling us what we should do and how we should preserve the uterus in most of the cases. So the indications for hysterectomy should be correct indication. Then comes to decide the route of surgery. Whether to remove adnexa or not, you have to discuss with the patient, and you have to improve the quality of your surgery and the quality of patient's life. Actually, patient education goes a long way. Don't resort to hysterectomy. Counsel her that AUB requires chronic therapy. She has to come for regular follow whenever you are calling her, and tell her and encourage her to maintain good menstrual calendar. Hysterectomy on demand should never be entertained. Do evidence-based counseling. Don't create phobias for uterine cancer. And remember, the decision to do hysterectomy is in the domain of gynecologists and not the surgeons. So first, do no harm. So the key takeaways in perimenopausal women. Yes, just 10 seconds. TBS should be the investigation of choice due to its convenience, accuracy, and non-invasiveness. Endometrial biopsy, I have told you the indications. Hysteroscopy in selected cases, and hysterectomy should be the last source of treatment unless we have a strong reason to do so. These are the two documents which I will share in the groups. FOGSI has come out with the FOGSI focus on abnormal uterine bleeding. This was released when I was chairperson designate ICOG, and FOGSI ICOG GCPR was released when I was sitting ICOG chairpersons. So do go through all these documents to have more understanding about AUB. Thank you, friends. Thank you so much for your patient hearing.
Thank you, Dr. Lakshmi, for that excellent talk. And especially this talk was very important because most of the time, a large group of patients we are treating in the perimenopausal status. And if we scare them that cancer may happen or something like that, then definitely without any indication, we are going ahead with hysterectomies. So our primary role has to be to clear the diagnosis first, which you have duly said by transvaginal ultrasound is very good, endometrial biopsy, and definitely hysteroscopy is added in with it. I think so. Best is that we should be investigating patients appropriately and giving the treatment as required. And hysterectomy, ma'am, I would like to inform you that in Haryana, we are monthly, we are giving a report of all the hysterectomies which are being.
Yes, yes.
We are
Very
being
soon, government, yeah, everyone is supposed to do the hysterectomy audit in your premises. And very soon, I think they will start inspection and I will be asking the audit reports. As of
Yes.
now, they are not asking. And if your patient is less than 40 years, you have to have the opinion of 2 gynecologists to certify that she really needs hysterectomy.
Yes, at our place in Haryana, we are already sending monthly reports of all the hysterectomies which are being done. So I think
Yes.
so the way forward that everybody should be duly doing a good diagnosis and then going ahead first with the medical management and then only surgery if required. Thank you for that excellent talk.
Thank you.
Thank you. I would now like to invite the next speaker.
Yeah, Dr. Durgadas, I can see you.
Yeah,
You
yeah.
can invite.
Good evening, everybody. At the outset, I thank Dr. Sheila Mane, Dr. Sadhana Gupta, Dr. Lakshmi Srikhande, Dr. Shobha Gudi, and Dr. Ashok Kumar for giving me this opportunity. This is one of the wonderful topic you have chosen, masterclass, which is a day-to-day required thing. Coming to today's topic, which is Dr. Divya Agarwal is going to talk on. She's a gold medalist in her undergraduate days. She is the director of Ayushman Multi-Speciality Hospital and Akriti IVF Center, Varanasi. She was the secretary of IFS UP chapter. She was also the secretary of Varanasi Menopausal Society in the past president of Varanasi OBG Society in 21-22, organizing secretary of NZYF in 2023, scientific chairperson of Endometricon in 2024, and IFSCon in 2025. He was the EC member of FOGSI Medical Disorders in Pregnancy Committee. She was also a joint secretary of ACOG in 2012, EMISCON 2021, and ISOPAP 2025. He was organizing hysteroscopy and IUA workshops in national and state level conferences. Her awards are she was a recipient of FOGSI Achievers Award and UPI ISAR IVF Achiever Award. She is a faculty in various national and international conferences. Her field of interest is gynec endoscopy and infertility and high-risk pregnancy. We are eager to hear you from you, madam, on hysteroscopic interventions. Already, Dr. Lakshmi Srikhande has laid the foundation. I think we'll hear more about it.
So much, sir, for your kind introduction. And first, at the outset, I would like to thank Lakshmi ma'am for giving me this opportunity to deliver the talk at such a prestigious platform. I'm really feeling obliged. And we have already discussed so much about the abnormal uterine bleeding, and we all know the main intention is to prevent the uterus, to save the uterus, and hysteroscopy is one of the very important part in saving the uterus. So I'm going to discuss my topic on hysteroscopic interventions in AUB. The AUB has already been discussed. We all know about the AUB and the causes of AUB, and it is a structure causes which is explained by Palm, and the Cohen, this non-structure causes are explained by Cohen. It has already been explained multiple times. So why do we talk about the hysteroscopy? Because the main advantage of hysteroscopy, we can do the direct visualization of uterine cavity. It's a gold standard for intracavity pathology. Simultaneously, we can do the diagnosis and do the treatment at the same time. Targeted biopsy under the direct vision. It is superior to blind curettage and transvaginal sonography. And most important, it is an outpatient procedure with an excellent tolerance and compliance. So the key indications are heavy menstrual bleeding, intramenstrual bleeding, postmenopausal bleeding, postcoital bleeding, or failed recurrent medical therapy, and abnormal findings like polyp or echogenic and lesions, endometrial hyperplasia, and the preoperative assessment sometimes before the endometrial ablation. So coming to the techniques, it's office hysteroscopy, which is most commonly used, and it is 2.9 to 4 millimeter diameter scope. And vaginoscopic approach, there is no need of holding the cervix with the help of a speculum. Most important, it can be done with a normal saline distension. No need of anesthesia, and we can use the mini sheath of about 5 French for operating as an operating channel. Then the operative hysteroscopy, it is a standard method which was used before, and it is a 5 to 9 millimeter resectoscope, and we can use monopolar or bipolar energy for performing the surgeries, glycine or saline irrigation, but there is a need of regional or general anesthesia, and in this we can use the wider surgical channel, that is 5 to 7 French. Distension media, it can be normal saline. In this, bipolar energy has to be used, and glycine, in which the monopolar energy, whenever we are doing any surgery with the monopolar energy, obviously we have to use the glycine. And CO2, which can be used for office diagnostic only, nowadays not routinely used. And we should keep a watch of fluid deficit, which should not ideally increase between 1000 to 1500 ml. So this is a ACOG committee opinion, which is describing about the hysteroscopic distending media. And the one is the low viscosity fluid media, which is electrolyte poor fluid like glycine, sorbitol, and the mannitol. And the maximum fluid deficit should not increase more than 1000 ml. Advantage is it is compatible with the radio frequency energy, and we can use the monopolar devices with this. But main disadvantage that there is a chances of this excessive absorption, and of these fluid can lead to hyponatremia, hyperammonemia, and decreased semen osmolality, resulting into the risk of seizures, cerebral edema, and death. The other type of distension media is the low viscosity fluid media, which contains the electrolyte like normal saline and the sodium ringal lactate. In this, we can increase the fluid deficit, and it can increase to 2500 ml. But again, we have to be careful in this patient also. But advantage that it is readily available, cost effective, it is an isotonic solution, and the media of choice during diagnostic hysteroscopy, as well as in operative cases where mechanical, laser, or bipolar energy is used. In this also, there is a risk of complication of fluid overload, causing the pulmonary edema and congestive heart failure. So this committee has given that written that careful attention should be paid to fluid input and output, with a particular attention to the fluid deficit, especially in cases of elderly patients and those with the cardiopulmonary or renal compromise. Just a second. So what are the hysteroscopic findings we normally get in cases of abnormal uterine bleeding? It might be endometrial polyp. It is a smooth pedunculated sessile lesions, maybe single or multiple, and most common finding, it is around 25 to 40%. Submucous fibroids, it can be type 0, 1, or 2. Endometrial hyperplasia, which presents as irregular thickened papillary or glandular type of pattern. In this case, directed biopsy is mandatory. And endometrial carcinoma, when this tissue is irregular, friable, and necrotic, again in the biopsy is very important. So coming to the management part, this therapeutic hysteroscopic procedures which are performed, that is hysteroscopic polypectomy, and it can be done by various methods. That is most commonly used as scissors and grasping phosphorus, or we can also use, if it is a large type of polyp, we can use the monopolar or bipolar resectoscopes, or there are other equipment like electrosurgical vaporization, and sometime nowadays we are coming with the hysteroscopic morcellators like True Clear and MyoSures, and they are quite effective in managing the polyps. And this is a small video we can see. In this, the endometrial polyp is being excised with the help of scissor, because this patient still wants to conceive. And the scissor does not cause the fibrosis. So the success rate of hysteroscopic polypectomy is around 75 to 100%. There is chances of recurrence, but if there is postmenopausal polyp, it should be sent for histopathology to exclude the malignancy. Then coming to the submucous fibroid, it can be type 0, 1, or 2 according to the FIGO classification. And the type 0 is pedunculated entirely intracavity. Type 1 less than 50% is intramural, and type 2 is more than 50% intramural. So while we are performing this hysteroscopic myomectomy, we have to find a guideline which will help to know whether it is a complex procedure and how should we proceed. So this is a Lamarck-Schumacher myoma classification or a step W classification, and they indicates the degree of difficulty and complexity of hysteroscopic myomectomy. So depending upon the size, penetration, base, topography, or whether they are in the lateral wall, we do the scoring, and according to the score we decide. If it is type 0 to 4, it means it is a low complexity hysteroscopic myomectomy. It is 5 to 6, it is a complex hysteroscopic myomectomy, and we should consider using GnRH analog, or we should perform the two-step surgery. And if it is a score is quite high, like between 7 to 9, we should find a non-hysteroscopic technique method to manage them. Instead of hysteroscopy, we should go for laparoscopy. So the hysteroscopic myomectomy, there are various methods like slicing technique, morcellation, and if it is a large fibroid, we may need two-stage procedure. The best results are with the type 0 and type 1. Type 2 may require combined approach, but there are risks of the complication like fluid overload, perforation, and we should be careful of them. So hysteroscopic myomectomy we can do with the slicing technique. If we are using monopolar energy, then the distension media should be 1.5 glycine, or as already discussed, bipolar energy, we should use this ringalectide or the normal saline. And this is a small video. We can see we are using the loop and bipolar loop and resecting the myoma with the slicing technique. Other method is vaporizing electrode resectoscope. It is a roller ball method and vaporizes the myoma, so avoid the need of frequent chip removal. But however, it precludes we do not get the tissue for the pathological examination. And this is a new method now. We are having a morcellators technique, that is a hysteroscopic tissue removal system. In this, we can perform the fragmentation and suction of the polyps and fibroids, mainly used for type 0 and 1. The limitation is high cost of the disposable element, as well as difficulty in resecting the fundal fibroid, deep type 2 fibroid, and calcified fibroid. And this is a small video. We can see this morcellator, and there is removing the myoma with the fragmentation method. Then endometrial ablation is also normally it's not needed, but sometimes when the patient any type of medical management fails and the patient is then in those cases we like to go for endometrial ablation, and it destroys the endometrium to reduce or eliminate menstruation. And there are various type of hysteroscopic ablation methods. First generation is resectoscope, which was initially used. We use the roller ball or loop resection using the either energy or laser. And second generation, that is non-resectoscopic. In this, we use the thermal balloon or thermachoice, microwave, this bipolar mesh or NovaShield, and cryoablation or the hydrotherapy. I can use the cold method, or we can use the heat method for the ablation of the endometrium. This is a chart which is explaining all the methods. In first generation, we know this is TCRE, that means the loops excise the endometrium and block. Rollerball ablation, that basically it causes the thermal coagulation to the depth of 3 to 4 millimeter, and ND-YAG laser, that is laser fiber, and now it has superseded the other methods. Then the second generation, it is the NovaShield, in which we use the bipolar radiofrequency energy mesh, thermachoice, in which intrauterine balloon, that is 87 degrees Celsius. We can also use the microwave, thermal energy, or the cryoablation. And we can compare all the methods in this chart, and we can see this NovaSure, it has got a high satisfaction rate of about 92%, and also causes the amenorrhea rate is around 52%, 56%. So the NovaSure, basically it is used, and it is a very short procedure and works by delivering a controlled dose of radiofrequency energy to permanently destroy the endometrium. It has a high success rate of about 80 to 90% of reduced bleeding and 40 to 50% of amenorrhea rate, but not complications, contraindications. Those who are desirous for future pregnancy, endometrial cancer, recent uterine surgery, or if the cavity length is less than 6 centimeter or 10 centimeter, depending upon the device. Then whenever we are performing the hysteroscopy and we see any type of suspicious lesion, we should take the directed biopsy. It's really very much beneficial and much superior to blind UHC for the focal lesions. And this is a recent publication we can see, and they have concluded, this is a publication in 2025, and they have concluded that this hysteroscopic directed biopsy has much superior diagnostic accuracy compared to the blind technique. So complications, the various complications, serious complication, fluid overload. Whenever we are performing any type of surgery with a hysteroscopy, we should be careful about the fluid deficit. Ideally, it should not increase more than 1000 ml, but in healthy patient, it may increase to 1500. If we suspect of the fluid overload, immediately we should give the IV furosemide, serum electrolyte checking should be done, and if need, then there is a need of ICU also. Serious complications like uterine perforations, moderate, it can be cervical injury or the hemorrhage, and the rare complication can be gas embolism if we use the CO2. Normally, we are not using the CO2 for the procedures. And the low complications, there is a risk of infection. Normally, with the office hysteroscopy, there is no need of using the prophylactic antibiotic, but sometimes if we suspect anything, we should use the prophylactic antibiotic. So these are the indications, absolute
Sorry,
indications.
ma'am, your time is up.
Yes, I'm just concluding. And the takeaways, hysteroscopy is the gold standard for evaluation, and the palm coin classification guides the systemic evaluation. Office hysteroscopy is well tolerated, cost effective, and avoids the general anesthesia. Meticulous fluid balance monitoring and adherence to distension media protocol are essential to prevent the serious complication. And all the evidences have shown this supports the hysteroscopy as a cornerstone of modern gynecological practice. So we must, all the gynecology must thank the hysteroscopy for such a taking a leap and helping us to save the uterus. Thank you.
Thank you, madam, for the excellent talk. Really, again, very good messages. As there are nearly 400 logins, I suggest that each and every one of us should learn how to do office cystoscope. That is the because that's the basics. So to learn the office cystoscope, I tell the juniors before performing any hysterectomy, starts putting a cystoscope into the uterus and see, get used to the procedure. Then slowly you can catch up for the office cystoscope and operative cystoscope. And thank you, madam, for the excellent talk. Once again, it was the only mission is save uterus. That was the basic of the talk. Thank you, madam.
May I request Dr. Aruna Kumari to please take over the third talk? Please introduce and you can conclude also. Dr.
Good evening, yes, madam. Am I audible? Good evening, madam.
Yeah.
Good evening, everybody. And first, let me thank Sheila Mana, madam, Lakshmi Shrikanda, madam, Shobha Gudi, madam, and Patrick, sir, for giving me, for including me in this prestigious platform. Thank you so much. And I would like to invite all of you to attend South Zone Yuva FOGSI, which is going to be held in Rajahmundry in September 4th, 5th, 6th of September. Thank you so much.
Please invite Dr. Todani. Can you see his slide, Aruna? I think we have lost her.
Hello.
Dr. Aruna? Dr. Durgadas, please introduce him briefly and invite him for his talk.
Yes. It's my proud privilege once again to come to this platform and invite Dr. Ashok Kumar Todani. He's a past secretary and president of Durgapur OB Society and national faculty of AACOG for 18 years. And he has won the CS Dawn Prize of AACOG in 1990. Till then, he was. You can make out with such a long scene what academic career you are having. He has delivered 162 lectures. He has given 17 publications. A faculty of so many vaginal surgery workshops and ASU and at many ASUG conferences for 18 years. And he has operated NDVH live at AACOG Bhubaneswar. And he was a member of FOGSI. He was the ex-vice dean of Indian College of Medical Ultrasound. With these accolades, please, we were eager to hear you, sir.
Welcome, Dr. Todani.
Yes, madam. Full screen.
Yeah.
Can you see my presentation, please? Slide.
Yeah, please make it full screen.
Full screen. It's all right now?
Yes, great.
At the very outset, I would like to thank the organizers, this fantastic team, ICOG, particularly Dr. Lakshmi Srikhande, for giving this fantastic opportunity to present my views on the topic hysterectomy, when, which route, and counseling. We consider patient first. Lord Moynihan said, "We have made surgery safe for our patients. Let us make our patients safe for surgery." Hysterectomy is the commonest gynecological operation done. It was started in the era when anesthesia or antibiotics did not exist. Generalized thinking is that abdominal route for hysterectomy is for more serious conditions, whereas vaginal route is for less serious conditions. Guiding fear is narrow space, narrow accessibility, and needs more working confidence. We have to overcome all this. Vaginal hysterectomy for prolapse remedy is done by all gynecs, but non-descent vaginal hysterectomy needs extra training, expertise, and orientation. Hardly single dose post-operative analgesic is needed. Any urgency for hysterectomy? Only rarely does the womb needs to be removed immediately on an emergency basis. That may need to be done to avoid life-threatening and or serious complications due to things like serious injuries, severe infections, or uncontrollable bleeding during childbirth. Purpose of hysterectomy is cancer treatment or prevention like in precancerous changes, health conditions like fibroids and endometriosis, irregular vaginal bleeding, gender affirming care like in transgenders. We have to be cautious as 1 in 350 women undergoing hysterectomy or myomectomy for fibroids has an unsuspected or undiagnosed uterine malignancy which can disseminate intraperitoneally in case of abdominal or laparoscopic morcellation. Here, vaginal hysterectomy scores over other routes. Coming to types of hysterectomy, basically 3 types: partial or supracervical, total or complete, and radical, which is carried out in select cases of cervical cancer. There are proponents for subtotal hysterectomy. Kilku series is there. It suggested that total hysterectomy was associated with a reduction in frequency of orgasm and less improvement in dyspareunia when compared with subtotal procedure. This leads to sexual dissatisfaction. Psychology aggravated the sense of total loss by total removal of womb. However, in era of evidence-based medicine, subtotal hysterectomy can't be justified to be superior to total hysterectomy. We have to ensure consent for all aspects and types of procedures from the patient, explaining different routes and different varieties. When to perform a hysterectomy? Hysterectomy is typically recommended when serious uterine conditions cannot be effectively treated with less invasive methods or pose a significant health risk. Abnormal or heavy bleeding, uterine fibroids, prolapse when the uterus descends into the vaginal canal causing discomfort or urinary bowel issues, and non-surgical options like pessaries or pelvic floor therapy are insufficient. Pregnancy complications like placenta accreta spectrum, endometriosis and chronic pelvic pain. Cancer hysterectomy is often necessary for cancers of the uterus, cervix, ovaries, or vagina. Prompt surgery can prevent cancer spread and improve outcomes. Gender affirming surgery in transgender individuals may choose hysterectomy as part of gender affirming care. Factors to consider before surgery are age and fertility. Other alternative treatment needs to be suggested for patients desirous for children and wanting to retain menses. Alternative treatment modalities available. Less invasive options include hormonal therapy, endometrial ablation, uterine artery embolization, or myomectomy for fibroids, and pelvic floor therapy for prolapse. Types of hysterectomy we have already discussed. Recovery and risk. Recovery typically takes 4 to 6 weeks. Risks include infection, bleeding, hormonal changes if ovaries are removed, and potential long-term effects on sexual and pelvic health. Coming to routes of hysterectomy, it's vaginal, abdominal, laparoscopic, robot-assisted, and combined approaches. And V-notes is a mixed vaginal laparoscopic approach. Factors influencing route selection. First, the patient anatomy, size and shape of the uterus and vagina, that's presence of prolapse, extent of disease, additions, fibroids, endometriosis or malignancy, concurrent procedures, need for oophorectomy, salpingectomy, or other pelvic surgeries, surgeon experience and available technology, training, case volume, and hospital resources, patient preference, informed discussion about recovery, scarring, and risks. Speed of operation is directly related to good results and less post-operative morbidity. Thus, try to complete in minutes and not in hours. First, coming to abdominal route, advantages are symptom relief in intense, complicated anatomy and serious cases, clear surgical access. The abdominal approach provides a direct view of pelvic organs, making it suitable for complex cases such as large fibroids, extensive endometriosis or cancer, reduced malignancy rate due to wider and extensive tissue resection, needs less expertise and can be done by beginners. Coming to disadvantages, these are increased risk of infection, bleeding, blood clots, injury to nearing organs, longer recovery time, increased post-operative pain, more parietal complications, sexual function consideration, particularly if cervix is removed. Next, the laparoscopic hysterectomy advantages are minimally invasive approach, uses a small incisions resulting in less pain, smaller scars boosting morale, and a low risk of infection compared to traditional abdominal hysterectomy. Faster recovery, reduced blood loss, presence of sexual function. Many report no long-term negative impact on sexual function. Disadvantages are surgical risk, increased risk of visceral injuries, technical complexity, requiring a skilled surgeon, and we have a longer operating time, cost consideration, and gas-related discomfort. Vaginal hysterectomy merits are no scar on abdomen, shorter hospital stay, reduced post-operative pain and discomfort, lower cost, daycare procedures are gaining popularity, less post-operative complications, adenexectomy done as well, volume reduction done by morcellation. Coming to demerits, needs vast experience and patience. Have to avoid absolute contraindicated cases like malignancy, extensive pelvic adhesions, repaired VVF, RVF, etc. The transition of routes is there with increasing expertise and practice. Experts try to accomplish every step laparoscopically, whatever is done by opening the abdomen. Doctors undertake vaginal hysterectomy usually after they have mastered abdominal and laparoscopic route. Robotic hysterectomy demands much more cost, but less learning curve in instrument handling and suturing technique. With rise in incidence of caesarean section in most countries, a surgeon of tomorrow will be confronted with an alternate woman scheduled for hysterectomy with history of one or more caesarean deliveries in past. So don't get afraid of caesarean section scars. What masters say, Dr. Harry Rick, who pioneered and performed first LAVH in 1989 and first ELH in 1993, recommended vaginal hysterectomy when it can be safely carried out in preference to laparoscopic or abdominal hysterectomy. Laparoscopic surgery should better be used to convert abdominal into vaginal hysterectomy. The spectrum of hysterectomy varies from descent to non-descent surgery. Prestigious ACOG committee opinion November 2017 says vaginal hysterectomy is preferable to abdominal route, and there is no evidence to support laparoscopic hysterectomy if vaginal hysterectomy can be done safely. Coming to counseling part that I talk, or it is a talk therapy. Before surgery, counseling is extremely important as a healthcare professional. Providing thorough and empathetic counseling before a hysterectomy is crucial, as she can't be pregnant anymore and no menses will be there. In fact, it helps patients understand both physical and emotional aspects, detailed explanation of patient's condition, alternative treatments and their effectiveness, types of hysterectomy procedures, risks and benefits, recovery timeline, emotional and hormonal impact, encourage open discussions. Therefore, patients can ask questions freely and make confident decisions. Detailed review of patient's medical history and mutual discussion should be there. Understanding patient medical history, gynecological conditions, surgical history, family history, her current symptoms, discussing the indications for hysterectomy, exploring different types of hysterectomy, explaining benefits and risk of the surgery, long-term benefits, psychological impact, other alternative treatment options if long-term medications are needed, preparing patients mentally and physically for the surgery. Benefits of hysterectomy treatment and explained during counseling: permanent relief from heavy bleeding, elimination of chronic pelvic pain, treatment of cancerous conditions, improved quality of life, no risk of uterine-related diseases. Patients often feel physically and emotionally better after recovery. Explain recovery after hysterectomy. Recovery depends on the type and route of surgery. Most patients recover satisfactorily. Recovery timeline, hospital stay is 1 to 3 days depending on the procedure. Initial recovery 2 to 4 weeks and full recovery by 6 to 8 weeks. Post-surgical care, take prescribed medications regularly, avoid heavy weight lifting, maintain proper hygiene, follow a healthy diet, attend follow-up visits. In addition, emotional support plays an important role in recovery. Counseling sessions for emotional and hormonal support should be there for patients' well-being. Hormone therapy guidance if needed. Lifestyle and wellness advice ensure that patients feel comfortable and confident throughout their journey. Choose NDVH, in my opinion, because NDVH is least invasive, laparoscopic surgery is more invasive, and abdominal hysterectomy is most invasive. Vaginal subtotal hysterectomy is also feasible. It is done by experts, no doubt. Friends, old will always be gold. First vaginal hysterectomy was done by Soranus in Greece in 120 AD, whereas first transabdominal hysterectomy was performed by Charles Clay in Manchester on 17th of November 1843. She will bless you heavily if there is no abdominal scar inflicted upon her. Put a stop to unnecessary hysterectomies. There is a small 2 minutes video. You can go through this. Edited vaginal hysterectomy. Thus, there is the local infiltration. There is a large polyp you can see at the external os. Vaginal pap smear proved that it has got dysplastic cells, and we decided to have NDVH. First, the polyp is being removed for biopsy purposes. Then after infiltration, put a bolt cut on the anterior wall and cut till the cervical wall is exposed or cervical tissue is exposed. And we have to take care of the bladder. You can see the tissue underneath, and this is the peritoneum I am opening up. You can see nicely the anterior pouch. Once you can enter the anterior and the posterior pouch, your 50% of the job is done and your confidence improves further. This is the cat's paw. This is very useful in holding the uterus. We use as a routine bike clamp where there is minimal post-operative pain. Avoid tissue charring always.
Sir, time is up.
Okay, thank you. Thanks for your patient hearing. My parents and my grandchildren would like to thank you all. Thank you very much for your patient hearing.
Arunakumari, madam.
Thank you, sir. Thank you, sir. Thank you for excellent lecture, which is excellently covered all aspects of the hysterectomy, various routes, various indications, and various types of hysterectomy. As you said, we all should do minimally invasive surgeries like vaginal hysterectomy. We should learn to do NIDH, non-descent hysterectomy first. If it is not possible, the second option will be laparoscopic hysterectomy, and we should all do abdominal hysterectomy when we are unable to do these less invasive procedures like severe pelvic adhesions, large uterus, and any where we have to do other surgeries like large fibroids, etc. Thank you, sir. Thank you so much.
Thank
Sir,
you,
you can conclude.
Once again.
And your video is also excellent, sir. But we are unable to complete it.
Just 2 minutes video. I could not get the opportunity to demonstrate.
Yeah, because of the time.
Yeah, only 2 minutes video it was there.
Thank you, sir.
Thank you.
To conclude the session, yeah, in all cases, first we should select non-invasive procedures. After diagnosing the AUB, we should try to diagnose the cause of AUB. If it is some structural reason like polyp or submucous fibroid, as madam said, we should try to do less invasive procedure like hysteroscopic removal. which is excellently demonstrated by our speaker. If it is not feasible to do these, if there are no structural reasons, then we should go for other causes of, we should evaluate the other causes of AUB, and we'll try to use either medical management or LNG IUD. And if they are not suitable, if the medical therapy fails, or if patient is very much interested in going ahead with hysterectomy because of long duration of our suffering, then again we should first select the less invasive procedure. The last option is the abdominal hysterectomy. Thank you so much for giving me this opportunity. Thank you, sir. Thank you, madam.
Thank you, ICOG, for the platform you have given for this prestigious masterclass. Thank you.
Thank you so much.
Thank you, Dr. Lakshmi. Thank you for this opportunity.
Shall we proceed with the next session? I think we have a fantastic panel discussion which is awaited. We had 3 excellent talks in this session as well. And is Dr. Shobha around? Yeah, Shobha is there. Dr. Shobha, I've sent you an unmute request and a video request.
Yeah, got it, Pratik. Yes, got it. So now it is time for the most vibrant session. Actually, I must thank the speakers, and they made their place today by, bringing in excellent deliberation on the surgical approach, because today it looks more and more medical, every gynec management. But in the face of that, they have managed to create a space for surgical approach. And I think the delegates have appreciated it well from the way I have seen the reaction in the chat box. So keep at it, ask your questions, and they will sort it out immediately. So the session 3 is a panel on medical versus surgical decision making. Hopefully, most of the questions will get answered now. Managing failed medical therapy is what is going to be deliberated on. Can I have the CV of the moderators, please? Hello.
Yes,
Yeah.
ma'am. It's moderator CV.
Yeah. Please put na. Yeah. So the first moderator is none other than Dr. Komal Chavan, good friend, co-chairperson for me. We did a lot of work together. Even after her chairpersonship, she was in AMOGS with a sister committee for me, and same committee, family welfare, and that was also really enjoyable. Komal, you have been the vice president FOGSI 2025, very active. You were at that time. You were with me as governing council member, ICOG also. You have been richly awarded for your work throughout your career. Welcome to take up as moderator. Next, please.
Thank you.
Yeah, Komal. Nice to see. I'm sure this will be scintillating because you're doing it. Next, please. Hello. They are thinking I should read out the whole thing.
No, please. I think you should go
I'm not
ahead.
going to do that here.
Yeah.
Because everybody knows, I think it must have been read several times. So, Madan, welcome. I think this must be amongst the first ICOG which you are doing, if I'm not mistaken. But we look forward to your moderation today because you have been the zonal coordinator in AMOG so much and chairperson of AMOG Sexual Medicine. And you're soon going to take up as chairperson in FOGSI as well. We look forward to your tenure. Very lot of expectations from you. You have been the national coordinator for the same sexual health and STI committee, and of course, you have led your parent society ACLUJ as president, and you have served for the Maharashtra state in several ways. You are a fellow in aesthetic gynecology also. So it's quite an accomplished person. Welcome, Dr. Madan. So, Komal, you will introduce the panelists. How shall it be?
I don't have the CVs, but I do
Yeah,
have
CVs
names written in my
yeah.
CVs will be displayed. CVs will be displayed.
Yeah.
So carry on, Komal. You can give two-liners for your panelists, and you can go ahead. You and Madan can split and do it.
Yeah.
So over to you. Over to you.
Thank you so much, Dr. Shobha Gudi, and great pleasure. Thank you, Dr. Lakshmi Madam, Dr. Sheila Mane, Dr. Pratik, and the ICOG team for this opportunity and a very focused topic of AUB, and I was glued to all the talks. So can you just keep changing the CVs? We have two experts in our panel. So I will introduce the experts and then the panelist, Dr. Madan can introduce. So expert is that, may I have the CVs? Just go the audiovisual team little faster. We have Dr. Ashish.
नीलिमा फटाफट दिखाओ और संजयता you can show.
Mukhopadhyay and Dr. MC Patel, who are our experts for today. And I think they all are very well known. Dr. MC Patel has been earlier the vice president of FOGSI. He is a very senior gynecologist expert in medical legal field from Ahmedabad. Welcome, Dr. MC Patel, sir. Then we have Dr. Ashish Kumar Mukhopadhyay. We all know him from
Nilima?
the scientific chair of the AICOG Kolkata and also a former vice president of FOGSI. Nilima, please, the CVs. This is what I know. I have been introducing them.
Yeah, I know. But they have got CVs of everyone. I don't know why
Please,
they are not paying attention. Technical team is also having, so Nilima is also having.
Don't worry,
Are
you
you
don't need
with
an
me?
introduction.
You can just
start.
read the
Yeah.
read the names and start. Komal, we are already behind schedule.
Okay, I'll do that. I'll share my screen. I have the names already. Okay.
Nilima actually thinks that they are not experts, they are Y parts. That's why she's not showing the CVs, you know.
She knows that you all are very well known to the entire India. That is why she is not showing.
She's not showing because of that. Yeah. So all are very expert and everything. So I will share my screen directly. Wait.
Yeah, please start with the panel.
No, I think I can't share because ICOG team is still sharing the screen.
Now you stop, Sanjay, the technical team, please stop your screen share and let them start the panel. ICOG team, please stop screen sharing.
Yes, ma'am. Yes.
I don't know why the platform.
So it is coming. I'm not able to share.
Yeah, because they are trying to share. The tech team is trying to share.
Some
I am telling
technical
them to
glitches.
stop.
Wait, yeah. Just a minute. I'm just technical glitches.
There is some technical glitch, I think.
Just wait.
Because
We'll wait. So I will just call out the panelists. I have it with me.
Yeah.
I welcome Dr. Upma Saxena, Dr. Meenakshi Ahuja, Dr. Narsavani Sunkura, Dr. Pradeep Ganiga, Dr. Himlina Gautam, Dr. Meenu Vaish, Dr. Arpita Gandhi, Dr. Umayal Murugasen, Dr. Rekha Rajendra Kumar, and Dr. N. Chandra Ponusami. I think all are there. Please show your video on your video and your audio. Keep ready so that we can start with panel discussion. So I can see all of them, mostly all of them here. And now I'll share my screen. So is my screen visible now?
Yes, it's visible.
Yes.
So we'll begin, and I think we have to finish on time because we have a post-test session also.
Yes.
So we will fine. I think AUB has been much discussed, and we know what is normal and abnormal, the definitions, everything, the ACOG, the FIGO classification, everything all has been discussed. And I think we have had a very good knowledge about most of the things, but what we are going to discuss is only the practical cases and a focused discussion in when the medical therapy fails and how do we go about, that transitioning from a medical to surgical therapy. So we begin with the first case. We have a 28-year-old female, Paris, heavy bleeding since 8 months. The hemoglobin has already dropped down to 8 grams. The TVS is normal. So, these are the classical patients who come to our OPD. So we start with our first panelist, Dr. Upma Saxena. What would be your basic, working diagnosis and how would you go about, managing this patient?
So, at the outset, I want to thank ICOG team for inviting me. It's always a privilege and honor to be here. So, coming to the case, she's a 28 years old. So, any women in a reproductive age group, first of all, I'll rule out a pregnancy complication. Though history is long, it's 8 months. I'll definitely do a UPT. And if not sure, even the beta SCG. And so most likely in this case, it could be anovulation that is the cause of her bleeding because many a times patient, they don't tell, they have a preceding amenorrhea followed by prolonged bleeding. So after ruling out the pregnancy complication, next will be the coin part of the. I will not think of coagulopathy in this case because she's already 20. She has previous cycles, so unlikely. But definitely, I look at the platelet count. And then in the ovulation, I've already said endometrial. Usually, if there is a history in a PCOS patient, at 28 also I have seen malignancy. So if I think she's a case of PCOS or your PMOS, then definitely I'll go for endometrial biopsy because this 8 months is a long time. And in this case, once you have ruled out pathology, first line management definitely will be could be COC because, or we can just first of all start her with tranexamic acid and mefenamic acid combination. We know that tranexamic acid reduce bleeding by almost 50% and mefenamic acid by 30. So combination, they work synergistically and will reduce bleeding. And if not responding this to first line, then I definitely think of, in this case, she has nulliparous. So before I start her on COC or any hormonal treatment, I'll ask her whether she's keen on getting she pregnant soon or not. And when is medical therapy considered a failure? So regarding this question, I'll say the medical therapy usually I'll try for 3 months, 3 to 6 months. If it fails, then I say the medical therapy
Before
is a failure. And role of
failure,
hysteroscopy here.
how would you graduate the medical therapy? You talked about prescribing first the tranexamic acid. What about the
and
hormonal therapy?
and
If you give
so
so
a role of hysteroscopy, I do hysteroscopy only if the endometrial ET is more than around 12 to 14 mm. If I think of a polyp, because that is also very important cause and which is a treatable cause. So hysteroscopy I do only if ET is more than 14 mm in a reproductive age.
Okay. Yeah, Dr. Meenakshi Ahuja, now coming back to the medical therapy. So would you be giving like the tranexamic acid and all that as a first line? What about the hormonal therapy? And what is your take upon the failure of medical therapy?
So thank you, Dr. Komal. So what I would like to say here, when you said also investigations needed, I'd definitely like to get a thyroid and prolactin done also. Because so many times we see that the endometrial thickness is okay because you said the TVS is normal. So I'm assuming the ET is fine.
Yes.
That, it could be a central hormonal disorder. So thyroid definitely in our country we need to rule out before we start the management. Meanwhile, she's come with heavy bleeding, even though the history is 8 months. I would say that she has not taken any treatment till then, so I wouldn't have expected it to get okay on its own. Probably tranexamic acid is the first thing I would give. That's one pointer I want to make, especially for the postgraduate students, that mostly the tablets which are available are 500 milligrams thrice a day or whatever we use. But the therapeutic dose is 1 to 1.2 gram thrice a day. So actually using more of tranexamic acid might give us results. And the point is that we will give it for 3 to 5 days during the bleeding that is happening. So if that is working for her, she's comfortable and she's nulliparous, she's 28, she wants to plan pregnancies alongside, it's perfectly fine. And if she gets pregnant, obviously the AUB is also going to get okay with that. If the tranexamic acid is not working, her hemoglobin is already 8 grams. So I can't kind of be an experimental thing that keep on saying, okay, 6 months you take this. I would like to give her maybe an iron infusion also and put on iron and multivitamins as a supportive therapy. And that is the first thing I'll do. Along with that, of course, we will give her NSAIDs like naproxen or mefenamic acid. Mostly we are getting the fixed drug combinations of tranexamic acid with mefenamic acid also. But there again, you have to be mindful because the mefenamic acid, if you give them 2 tablets of those, the mefenamic acid also becomes too much. Now, if that is not working or she's coming with bleeding which is continuous and the ultrasound is fine, then my next option would be progesterone plain, because I know that progesterone usually will stop the bleeding for sure. So then I would start with if the bleeding is continuous, maybe a heavier dose of progesterone, and day 5 to day 25 might be required. And if I feel that, okay, maybe just a day, maybe day in the middle of the cycle I can give, that might also work. So I would give it for 21 days, starting with 5 to 10 milligrams. Usually I would start with the 10 higher dose. Now we have again sustained release formulations. So I would get progesterone at Registron CR is what I would use, 10 milligrams for 21 days. And or if it is controlled on 5 milligrams also, that should be okay. So I might also give it to her for only 10 days a month, starting from day 16 to day 25 also. If the patient feels that, the nuisance of trying to remember when to take the progesterone is difficult, and she could be taking this even when she's planning a pregnancy. However, if she's not keen to plan a pregnancy, cyclical oral contraceptive pills seems to be the most convenient and easy choice. So because that would usually decrease her bleeding also and keep her periods on time, and she's not looking for a pregnancy, it's a win-win for all. And mostly it
Hemoglobin will also
decreases
rise.
the flow by 50%.
Yes.
So
So I
that is
just
what
want to
I
add
use.
one thing,
I don't think I'll be
Miss.
using a device or anything in such a patient because she's nulliparous. She would be looking for a pregnancy soon, is what I hope. There are also certain formulations like we have the Dynogest and ethinyl estradiol valerate combinations available now. So those are also said that the patient will have a decrease in the bleeding by over 60% within 6 months. Compared to the normal OCPs, but we have to keep the cost in consideration when we are advising those.
Yes, I think Dr. Upma wanted to make
I
point.
just
Yes,
want to say for
very
her,
well.
she was anemic also. For anemia, I will
Yeah.
definitely give her IV iron, and we are using FCM a lot for treating anemia. So 8.5, if it's microcytic anemia, and definitely if it's macrocytic folic acid.
Yeah.
And if she's acutely bleeding, then definitely I'll start her on norethistron high doses for 5 days, and then then maintenance dose for next 16 days. I usually give for 21 days if she's acutely bleeding and anemic. Otherwise, we can directly start her on COC next cycle.
Yes, I think correction of anemia, everything should go side by side because we
Side
want,
by side.
yeah, patient to
And
be
investigate.
very well. And then planning pregnancy can be taken when her general condition stabilizes and, the bleeding also settles. So these are the guidelines, references. I think you all have covered everything. The role of hysteroscopy comes when there is a polyp, and to diagnose a polyp, if it can be diagnosed in an ultrasound, but yes, then removal by a hysteroscopic way and the polyp sent for histopathology is very, very important. So diagnose a polyp and treat it. And these are the management guidelines, whether some patients who do come in an emergency and they are bleeding profusely, so they may require an inpatient management also, but you can also do an outpatient management, which was very nicely, summarized by on the panel. So the drugs go the same way in the manner described. But you need to know that in an inpatient management, you need to know if it is the medical management is failing, like you have tried all levels of drugs and it has failed. And then comes the role for the procedural therapy, that you need to know that, yes, there is some problem which is happening and the bleeding is not controlled, or you have given the treatment for one cycle and the patient comes back again in the next cycle with a bleeding. And those patients may require something which we need to evaluate more in that case. And then we need to undergo any procedure. So this is how the outlook comes for the first case. Usually, I think in our experience, Dr. Upma, Dr. Minakshi, or anyone on the panelists, I think they would agree that at a young age, with the bleeding of this and starting the drugs, most of the patients do respond.
Yeah.
What about the opinion of the panel?
I have one thing to tell me.
Yeah. Now coming to our
Yeah.
expert. Yes. Dr. Ashish.
Yes, Komal. Thank you very much for putting up this excellent case. And I thank profusely Dr. Lakshmi Srikhande. I always say ICOG mein Lakshmi aayi hai, and she is very, very enthusiastic always. She's fantastic. So my thanks go to the ICOG team. Now the diagnosis in this case is AUBO or AUBE, right? You agree?
Yes.
Okay. Now I also agree that the serum TSH, prolactin, and I'll go for coagulation profile in this case also, although it's a bit higher age. And tranexamic acid plus minus NSAIDs is the first line of therapy. But about one thing, intravenous iron you're talking about, 8.5 hemoglobin is there. Unless the bleeding is recurrent and profuse, I'll rather start with the oral iron. That also works because it's a wrong concept that the IV iron works faster. It is not so. Oral iron and IV iron takes the same amount of time to raise the hem.
That's true. But compliance, because of the
Yes,
compliance,
yes.
most Indian women, they don't take it, and then they come less than 6 gram per cent in shop.
Absorption also, yeah. And the
Absorption and compliance.
You never know, this may be
Also, I
compliant.
agree with Dr. Upma. The problem is that, sir, if we are not giving her IV iron in the first go, probably one dose I'd like to give her IV, because in a month when she comes back with 7.5 or 6, that would not be acceptable.
And
So maybe one
she'll
IV
mark on
iron and then
pregnancy
we can
also.
continue. After 2 months, I would probably go on oral iron later.
I think, yeah. So the correction of anemia, we all agree.
Is very
So Dr.
important.
Ashish can go ahead. Yeah. Yeah.
Yes, actually, you see, IV iron has got its own limitation also. But if someone believes that IV iron will improve the anemia faster, that's not right.
No.
Yeah, so
That's
it will not improve faster. Only thing, it both
only
will
thing
take
is
2 to
that
3 weeks, but
you
it's
are
just a compliance.
ensuring that that amount of iron has been put inside the body of the.
Yes, sir.
It has got its own problem also. And I think that if you can try for the oral, unless the bleeding is excessive and recurrent and profuse. So I think that those are the cases where you can have that, because or rather patient gives a history of non-compliance to oral iron before this event. That is also possible.
Yes, I think very correct points you have made, and we move on to the next case. We have 5 cases lined up, and Dr. Madan, you can go ahead.
Yes, thank you, Komal ma'am. Thank you, ICOG, for having me here. This is again a very wonderful case, which is perimenopausal, 38 years. She has completed her family, and she is bleeding heavily since 1 year. Almost she has received all the medications like tranexamic acid, combined OCPs, progesterone therapy, but persistent symptoms are there. And she has been investigated with transvaginal ultrasound, which shows a 3.5 centimeter of submucosal fibroid. Then what next? How can we proceed in this case?
Yeah, we have our next 2 panelists, Dr. Sunkara and Dr. Ganiga.
Yes, Dr. Pradeep, Dr. Himalina is there, Dr. Meena
Yeah.
ma'am.
I think first of all, I will look for other non-gynecological causes also, because I don't always blame a submucosal fibroid in all the bleeding. Try to look for other causes, which rarely you may find out. Other than that, yeah, when you ruled out, I think specifically the fibroid is concerned, still going for myomectomy is an option. But after considering the patient, the mode of myomectomy, etc., has to be discussed with the patient to be taken a decision. No standard guidelines to tell that this myomectomy is going to help to 100%, because most of the time the associated conditions will be there. It could be the estrogen dependent conditions. So taking overall decision makes a very helpful as far the patient age is concerned. The concern is save uterus movement and going for myomectomy irrespective of her fertility. Completion of family is option for me as per this case is concerned.
She has already completed a family.
Yeah.
Which options you can put? Suppose she is ready for myomectomy, or if she wants to postpone her myomectomy, what will be your choice?
I think
She is
now
not ready at present for myomectomy.
Yeah, we have this generis, the antagonist in the market. I think everyone wants to put, but I have certain experience. Within 2 to 3 months, I didn't get a remarkable benefit in my few number of patients. But still, I counsel the patient for the antagonist, and I hope some certain patients have got the benefit. There's a chance to put them and to see for the result. Meanwhile, I should see that her hemoglobin is always maintained, and the other things, example, if she has a pain, etc., that has to be addressed.
Okay.
I think
At the same time, please.
Yeah, can I add?
Yeah, please, ma'am, please.
This patient is 38 years. She has completed a family and she is not responding to medical treatment. We can't put LNG IUS because the cavity is distorted. So option besides hysteroscopic resection, which we can decide on doing CIS or MRI, whether how much is FIGOS class 1 or 2, 0 or 1, then definitely if she agrees, we can go for hysteroscopic myomectomy and then put a Mirena after that, or LNG IUS after that. That can also be done. And or as she's completed family, she can also go, if she's not willing, she's 38, I think she should conserve her uterus. So you can go for uterine artery embolization or MR guided focus ultrasound. But knowing that there could be a recurrence at a later date, there may need for resurgery at a later date. So but at that point her uterus can be preserved, will be preserved. She's 38, so she can go ahead and go for these because family is completed. And she's symptomatic.
Okay. As in this case, there are no high risk factors. If she would have at high risk factor or family history of any malignancy, and then what will be your take? What you will have, whether you will go conservatively or
no, but she's a clean cut fibroid with a submucous. You are going to do a hysteroscopy, remove the fibroid, put in a Mirena. End of story.
And
she's comfortable for the next 5 years. She's
5 to 7, almost 7 years she will be comfortable doing a hysteroscopic
and
myomectomy.
then you can repeat it. Then you can repeat the Mirena. Obviously, we've ruled out malignancy. Malignancy would be a different story altogether.
The other option would be do hysteroscopic myomectomy and wait for some time. If she's totally comfortable, you don't have to put the Mirena at the same sitting. Wait for some time. If she's totally fine, then you don't have to put Mirena, and hysteroscopic myomectomy would suffice some cases.
No, but the point is putting the Mirena is not going to harm. And you know that someone who has fibroid has estrogen dominance. So ideally, you should be counseling for Mirena alongside.
Okay, means there are options of medications and LNG IUS. Both options are there, which the patient opts for. Okay.
I don't think so any need for medical because she's not nearing many perimenopause. So definitely we go for surgical management, which could be in form of hysteroscopic myomectomy with Mirena or UAE.
With Mirena.
I also
it's our job to convince the patient for the right thing.
After
you have to convince the patient for the right thing.
You can give her medical treatment
with Mirena
also.
Is the right option.
The myomectomy.
Okay, because the symptoms were due to the fibroid. If fibroid has been removed, then we can again try with medical treatment.
It will recur. The main problem is it will recur. So LNG will prevent the recurrence of fibroid.
Then we can go in for Mirena.
That's
not
why
recur all cases.
Yes.
Okay.
So
okay,
anybody has
Thank you.
experience on
We
Ulipristol?
can go for the next case also.
No, Ulipristol or Mifepristone, anybody has tried?
Ulipristol is a very toxic drug, should not be given. It can lead to hepatic failure, and you have to give it 3 months on and 1 month off. So usually we don't prefer it this age. 38.
And Mifepristone does not work in submucosal fibroids. Mifepristone does not work in submucosal fibroids. Even uterine embolization also does not work very good in submucosal fibroids.
Yes.
So, Dr. Komal, I think the message should be clear that the option that we should be advising is hysteroscopic myomectomy and Mirena insertion.
Yeah.
And if the patient is not ready for it, we should write it clearly on the prescription that she is not willing, but this is my management. Because looking for alternative options and later that prescription goes elsewhere also. And the other doctor will also say, ठीक चीज advice क्यों नहीं करी? So I think we should be very clear on what she needs. What she decides is her choice. But what she needs should be on the prescription always.
Yes, obviously, because the fibroid, though it looks small, it is a submucous one and it is causing a lot of problems where so much medical therapy has already been taken.
Absolutely. It's failed already.
You said writing and documentation. Do we have Dr. MC Patel to make an expert comment for this case? Our expert take?
I think sir is not there.
Yeah.
Madam, I want to highlight one thing. The trend among the population is very well know that everyone, there's a medical management for fibroid. People are getting information in the social media and everywhere. There's a medical management. We should not be in a hurry to advise a surgery in such a age group after trying certain effort in making symptomatically better by certain hormones or etc. I think then acceptability will be very good. If you tell in the first sitting only, I want to go for a myomectomy, the public trend is little different now. What we say in the...
So she's already had failed.
She already has taken.
She has failed medical management.
And
you
then
cannot change your diagnosis and management based on what the public thinks. Your management should be clear in your head.
Yeah, that's actually, we should agree with Meenakshi ma'am. He has already given the options. What options we have given to the patient right on the prescription, and let her accept any option. Let her accept.
Yeah, sure.
Okay.
But
It
that
will
was
I think
always right advice. This she
That should be
does not
documented
agree, then the next thing.
to
Yeah.
prevent the
two
misunderstanding.
observations. Can I have one or two observations?
Yes.
One is that, yes, hysteroscopic myomectomy, I think it is the preferred method of treatment over here. And I agree with Dr. Rekha Rajendra Kumar that you can wait for some time before putting in the Mirena because the uterus also needs time to involute, after the myomectomy. So let it come back to regain its original shape, normal shape and size, and then you can do that. Not immediately, maybe
Yeah,
after
the
some.
same sitting, no need.
No, no,
But
Yeah.
not same sitting.
Even later also, no need. You wait and watch. If she gets
Yeah,
this
you
again,
correct.
then only
You
you
can,
wait. It is
always
not
give it
always
a
a counter
in
of the
this
try.
patient, family complete, that's why I was saying. If not
so
family
what?
complete, definitely no.
That will talk about the
And
success of
Mirena is
the
quite locally acting, very
also.
safe.
Yes.
LNG IUS is quite safe option.
Secondly, I would like to say that the MR-guided focus ultrasound is perhaps not going to act on this case. And uterine embolization, yes, when the facilities are there available. And the last important observation is that there was talk about hysterectomy also, but mere completion of family is no longer an indication of hysterectomy these days.
Very true.
Yes.
And we are talking of save the uterus.
Yes,
Yeah,
save
we
the
have to
uterus.
tell her that her ovarian function will go downhill if she goes for hysterectomy. That is a very important part of the counseling.
We are talking about preserve the uterus, not save the uterus.
Yeah,
So preserve the
sorry,
uterus is
sorry.
very
Preserve the uterus, and that is the reason we told
Yes.
that the menstrual function and other things also have to continue, and the patient is
Yes.
young enough at 38 years. Yes, thank you. We'll move on because we have 5 cases lined and we have the time is ticking. So this is a 46-year-old, para 3, living 3, completed family, menorrhagia since 5 to 6 months, cycle irregular, 45 to 60 days since 6 months. She is already obese, diabetic, uterus is bulky. So now, Dr. Himlina, what about the differential? Because such patients come, and what will you feel the relevant investigations you will do?
So again, the relevant investigation initially are usually the same, like the CBC, the fasting PP. The thyroid is very important, and of course, in her case, TVS is extremely important for us. And I would suggest, if it is possible, we need to do a Pap smear also. And if the people is available, you can dig the people biopsy at the same sitting also when you're seeing the patient in the OPD. And so, of course, the TVS will guide us further regarding how to, manage this patient, and also the blood investigations. Regarding the road, TVS is the most important investigation for us, and biopsy, I have said that usually we do make it a point that perimenopausal AUB, we try to take a people after counseling the patient and a Pap smear, which is important. Hysteroscopy and endometrial sampling, yes, if the TVS
You will do
endometrial thickness.
OPD, or you will do a OPD-based biopsy, or you will go ahead for a hysteroscopic endometrial sampling?
So initially the people we can take at the OPD itself, but if the endometrial thickness is high, then office hysteroscopy is definitely indicated. And suppose we cannot take a sample by office hysteroscopy, then of course we'll have to do, not possible by a DNC, then we have to do a proper hysteroscopy and then a guided biopsy. I think that is the best.
I think there is no role of just a GNC. It is always a
Yes, no longer. Yes.
Hysteroscopic endometrial sampling. Yes.
I just want to add one thing. Usually, whenever a patient comes, we are suspecting endometrial hyperplasia or malignancy, we definitely go for a PIPL or sampling, endometrial sampling.
Yes.
And if that comes negative and the endometrium is thick, then we go for hysteroscopic guidance. If we are clinching the diagnosis of hyperplasia and your malignancy just on our PIPL biopsy or endosampler biopsy, then there is no need for hysteroscopy.
No need to go for a hysteroscopy.
But if you suspect that there is some problem and your report is not showing, then definitely you will go for hysteroscopic guided biopsy, because that is the gold standard.
Sometimes polyp is also not diagnosed by TVS. They show as an increased endometrial thickness. And then when we go inside and see that it is actually a polyp, then also hysteroscopy actually helps. We take the polyp out.
Yeah. So then also the ET will be thickened. So definitely ET thickened, you can go for first endometrial sampling. If you can clinch the diagnosis of hyperplasia, endometrial CA, carcinoma, good enough. No, then you go for directed biopsy, hysteroscopic.
So I think Dr. Ashish sir has raised his hand.
I think in this case, I will listen to the history very carefully. Is the bleeding irregular acyclical bleeding or it's a cyclical bleeding? In case of irregular acyclical and severe and profuse bleeding, I'll rather accelerate my management. But I prefer people biopsy in the OPD rather than admitting her for a hysteroscopy. Even in a daycare sampling, hysteroscopy is not adequate. Endometrium sampling, I'll push it to the second option because
Yes.
if something goes wrong with the people, then we'll only go for that.
Yeah, I agree.
Yes.
And another thing I'd like to highlight here is the endometrial sampling. We have to remember that the endometrial thickness is viable only after menopause. So long as the patient is bleeding cyclically, or rather she is reproductively active, hormonally active, there is no need to go for the no need to depend your management on the endometrial thickness.
Yeah. So now I think we discussed in depth about the endometrial sampling and everything, and now we have a report coming as a hyperplasia. So Dr. Meenu Vaish, what about the hyperplasia management? How will you actually, when that report comes, everybody is scared. So what will be the management?
Whenever there is a hyperplasia, we do ultrasound. We found in this particular case, there is a endometrium lining is 14 and she is a diabetic patient and with obesity. So when we find hyperplasia, it is a histopathological diagnosis. We have to do histopathology and we find whether it is a atypia or it is a normal hyperplasia. Whenever there is a normal hyperplasia, it is not atypia, then we have to do first line of treatment. Most probably I will like to do LNS intrauterine device in this particular case, and we can go ahead with the high doses of the progesterone also for giving for 12 to 14 days for this particular case. But LNG-IUS will be the right treatment for this particular case. If the
Absolutely.
patient is the case of the atypia, then it is in that particular case, in 30 to 40% cases, there are chances of endometrial malignancy. So in that particular case, we should go for hysterectomy and bilateral salpingophorectomy in this particular case.
Why
As far as
oophorectomy?
Why hysterectomy?
Why oophorectomy?
Because she
Why
is a
oophorectomy?
case of atypia and there is a chances of 30 to 40% chances of malignancy. As Dr. Lakshmi Shrikhande has said, we can save the ovaries, but in few years, definitely the ovaries are going to give up their function. So better to take out ovaries also if there is a chances of 30 to 40% chances of endometrial carcinoma. And that endometrial carcinoma, because she has a predisposed case of she is a predisposed case of the diabetic mellitus and obesity. So there is metabolic risk of endometrial involvement in this particular case. So I will definitely like to do oophorectomy, and I will like to have opinion about
We'll have to have
this.
opinion from the panel because I agree your opinion. So now, what about the panel? Anybody wants, Dr.
Yeah, I want to add in case of endometrial hyperplasia with atypia, definitely there is a 30% risk of progression to endometrial CA. And when we do hysterectomy, almost 30 to 50% may have malignancy in their specimen, which is shown after the in the histopathology of the hysterectomy specimen. So the endometrial CA metastasized to ovaries. So when I'm doing a hysterectomy for a patient with atypia, then I definitely go for TAH BSO. I'll remove do bilateral salpingophorectomy. I agree with her.
My answer would be the same if it is a hyperplasia with atypia. But if
I'm talking with atypia.
exactly,
atypia only we are talking.
If it is a simple hyperplasia, probably
Then there is no need. Definitely, I will not do hysterectomy. I'll counsel less than 1% risk of going to endometrial CA. That is, Dr. Lakshmi also shown there's a risk of 5% going to endometrial CA over a period of 20 years. So definitely, I'll keep her on follow-up, give her hormone therapy in the form of either LNG IUS or continuous progesterone for 6 months, repeat the biopsy, whether it's really it's regressed or it has, and I'll do hysterectomy if it's progressed. Otherwise, if regressed, we just keep a follow-up every 6 monthly endometrial biopsy by doing a pipple or
biopsy has to be done in this
medical
patient.
curettage followed by LNG in the very next cycle before the endometrium builds up. Soon after the next month.
That is the best option. So
yeah,
the LNG IUS is and with the, I just want to add, with LNG IUS you can just do along with that in situ you can do your endometrial biopsy using a pipple or a Carmen cannula.
Madam, if the endometrial hyperplasia without atypia, if she's responding to the conventional hormonal therapy, should we repeat the biopsy again after 6 months?
Yes. Yeah.
Yes.
Yeah.
Supposed to repeat it
should
after
repeat, because patient should be under your supervision continuously. So
Progression
you should
to
offer it to
atypia
those
is
who are under your supervision,
Yeah.
who are ready
Especially
for
in this
follow-up,
particular case.
who are
And
under
do that
follow-up.
She is a high risk with obesity, diabetes. So
That's
patient with
okay.
hyperplasia requires a follow-up. You will
Yeah.
treat. There is no need, because you know what happens. Sometimes people are jump into the idea was discussing hyperplasia and depth was that there are two hasty decisions taken regarding doing hysterectomy very fast. So
Cancer
these
phobia, mainly among.
the chances are very less, 5%, which was discussed in the talk also. So we just need to keep them under close monitoring and repeat
Follow-up,
it.
yeah.
Yeah.
And you can do that having LNG IUCD in situ.
Yeah.
this
So you can keep it for 7 years if she's agrees with it.
Yeah, LNG IUS only, and LNG IUS is shown to be very effective, I think, for all these things.
Yeah, for the
Ashish sir wants
Yes,
to add.
but I just wanted to reiterate that endometrial hyperplasia with atypia, yes, hysterectomy with bilateral salpingo oophorectomy is recommended, and if for any reason, not for normal circumstances, you need to have a hysterectomy in a case of endometrial hyperplasia alone, no atypia. If you need to have a hysterectomy, I'm repeatedly saying this, not usually would do that, then
no
only
need.
salpingectomy is recommended, oophorectomy is not indicated.
Yeah.
Yes,
correct.
I agree with sir.
All agree. I think the entire.
So we are doing self-injectmy because it reduces the risk of ovarian
we are doing
malignancy at a later date because of the stump theory. So we are doing self-injectmy with all our
all the cases.
hysterectomies, especially.
Yes, agreed. So very good. So I think we'll move on to the next case. Dr. Madan.
Yes, again, this is an interesting case. 42 years. She has only one child, 8 years old. She has severe dysmenorrhea, heavy bleeding, and upon the investigations, MRI has been done, which is suggestive of adenomyosis. Then, what are the medical options? LNGIUS, DNOJS, GnRH analogs. Which one you will prefer, and what is your opinion about the surgery in this case?
We have
I think Dr. Umayal madam is there.
Umayal.
Yeah. Yes,
Yeah,
for
Dr.
this
Umayal,
case,
ma'am.
actually, yeah, can you hear me?
Yeah, we can
Yeah.
hear you, madam.
Please.
Yeah, we can
she's
hear you.
42.
Arpita Gandhi,
she-
Dr. Umayal, yes.
Yeah, she's 42 years old and she's having her major complaint is pain. So probably like and it is a bulky uterus. So for her, maybe we can go for medical options. And we used to go for a Dynogest before, but now I think we are going more on LNG IUS, and we have now started giving elagolix for this patient. So, actually that is giving a good relief. Like we can give it for around 3 to 4 months and review again about the pain symptoms, and then probably like most of these patients actually are responding very well to both these regimens. So we can offer any one of these to these patients and then follow them up.
Suppose this patient is not affordable, poor, then what we will prefer? She is not affording for LNGIUS, and elagolix is too costly.
Simple OC pills continuously given also will be giving them some relief of pain.
She is also having heavy bleeding. Yeah, there is one combination of Dinogest with ethyl estradiol that can be tried. Plain Dinogest can be tried. Yeah.
Dynogest, yes.
What about surgical?
Before. That was Dynogest was the choice before. Like it was very, very good. But I think off late we are switching over to the usage of these two.
I think Dr. Madan has a very valid point, because the cost becomes a factor for many patients.
Yeah, especially in the rural.
For a longer time. Yeah.
But when
Uh,
you talk about the cost
is
factor,
the cheapest option
you should
among
tell
all.
them that it
Because
is for a long time, Dr.
yeah,
Madan.
it's for 7 years. So 3,000-4,000 for 7 years is a very cheap option.
OTP
So
for
we have to
7
convince
years is
them. We
more
have to
than
convince
that.
them about the
Yeah.
advantages
Maintenance
of
free.
this, and yeah.
That is
Yeah.
again
LNG will be cheaper than any other medicine we are finding.
I prefer LNG for this patient.
But
Yeah.
only thing I just want to
It's
I
add,
would
only 42
huh.
years.
Listeners,
Madan, I would say that for the first 3 months, for the
you have
first
to
3
add.
months with the LNG IUS, you must give her something so that she doesn't have a compliance issue with it. So if you give her with either
Add on therapy
Cevista
we can
or
give.
with OCPs for 3 months, then I think she will be happy with it.
So counseling about that you have to take medical therapy for 3 months because it will take time to act, and it's very important about the counseling and irregular bleeding, because these are two things which lead to treatment failure because the patient, they are not counseled properly.
Another thing you have to tell them is long-term use of LNG after 1 or 2 years may cause amenorrhea also, because
Yeah,
that
so
also
it
they'll be
menstrual
worried
harm.
about, not
Again,
just
it's
the
a
spotting.
counseling skill. There should
And
be
for follow-up, we
counseling.
have to
Yeah.
ask them to come
Follow.
for regular follow-up. That is very important. Most of these patients forget that they have a device. So
That's
it is
good.
for us to counsel them.
Dr.
These
Sopma,
They
today
are
I've
treated.
removed a device after 12 years. She didn't come for
Yeah, so they
follow-up.
should
Her
be told,
daughter-in-law
7
came to
years
get
they
the
have to
Mirena
remove
put.
it.
Her daughter-in-law came to get a Mirena put, and she said, "Mummy, to nickel, why need it?" But she's turned 60, but she's gets it out. She'd start bleeding again. I had to call the mother-in-law after counseling. Please come first. I'll remove your Mirena, only then I'll put your daughter-in-law's Mirena.
Yeah, that's so. After 7 years, they have to remove, and if they want, if they're still not attained their menopause, they go for second one. That is very important,
Second
also
one,
part of the
after a gap
counseling.
of 1 or 2 months.
Okay.
Most of the
Follow-up is
time
very
their
much necessary.
symptoms goes off, they develop menopause, and they are not happy with the amenorrhea. As Dr. Rekha has said, the patients are not happy. Most of the patients in Indian scenario, they are looking for they should have a monthly bleeding. They find it as a normal. Otherwise, Mirena is used as a contraceptive in UAE, in other countries, but in our scenario, they don't want amenorrhea. So we have to counsel them very, very nicely. It is important to counsel them, and it is very important to tell them that 3 months maybe there will be spotting, and we have to guide them. Counseling is very, very important.
What about the surgical
LNG in
management?
this case.
What
Dr.
about the
Madan,
surgical?
Dr. Madan, I would like to tell
Yes.
about 2 things here about LNG. One, in this case of adenomyosis, the volume or the bulk of the uterus is also going to reduce by 15 to 20%. But before that, in the beginning part, they tell them to come every 6 months, because in the adenomyosis, as somebody has written in the chat box, there are some chances of expulsion because of a myometrial contractions.
Yeah,
that is why follow-up is necessary. At least 6
that
months
is
of follow-up
important.
is
Follow-up
necessary.
is very important.
Counseling should include that you should call them every
Size of the uterus, the size of the uterus is also very important. If the endometrial cavity is very large, sometimes they get expelled. That also we have to
I
take
just
into
want to add one thing. The LNG IUS should never be put if uterine size is more than 12 weeks. Majority of time the failure occurs or expulsion occurs because of they are
large
put in
uterus,
a
not
so 12
successful.
if the 12 week size, more than 12 weeks, never put a Mirena.
Madam, I have one query is, if there is associated severe dysmenorrhea, in such a situation, it's always preferred to the oral preparation first rather than the LNG IVS, because she has a severe dysmenorrhea, she's not able to tolerate in every cycle.
Yeah,
it gets relieved. Usually it gets relieved, the dysmenorrhea. Patients are very happy.
With the LNG IVS, immediate relief.
3 to 4 weeks.
No, we can
3
give
to 4 months
electrolytes
it
for
takes.
2 to 3
For
months.
the initial month.
And my next question
Initial
is,
3 months,
in this case,
some
when surgery will be required? Your medical treatment, when we can call it is failed, and this patient will require surgery. In what
See,
conditions?
if she has a focal adenomyosis, which is quite large, then these patients usually don't respond that much to the medical management. And the dysmenorrhea also is not, she's not improving on a dysmenorrhea. And so in such cases, we have to discuss whether it is, she might need some surgical intervention in the form of adenomyomectomy per se, or even an hysterectomy for such cases, because we have seen even 8 centimeter size adenomyomatous swelling in the posterior wall of the uterus with severe dysmenorrhea. So since she has crossed at 40, we can even counsel her for an hysterectomy also, because in such cases, which is not responding.
Many times patient insists for
Not
hysterectomy.
responding. Yeah, who they are. See, LNG is the first choice. Elagolix can be used as a supplement. And some of these people who have focal adenomyosis may not respond to this management, especially these large ones. The LNG IUD falls off. It doesn't stay inside, and the pain continues. So for such patients, we can give them adenomyomectomy as a solution.
What is your experience with Elagolix? What is your experience with Elagolix in such cases?
Elagolix is good. Yes, actually pain is getting relieved very much, and the bleeding is also getting reduced in this first 2 to 3 cycles at least by 50%. So we can use Elagolix for these patients. So only for the past maybe.
Yeah. Any last take, any opinion, Dr. Arpita Gandhi, Dr. Chandra, you want to add on anything before we just wind up the panel?
Regarding the last case, I just want to say, if I will ask her to go for IVF rather than going for adenomyomectomy, because uterus is just bulky. She's 42. If she's keen on having a second baby.
No, not for this case.
In this particular, sometimes we find that adenomyosis, a patient is looking for fertility. It's become very difficult because their implantation is very, very pure. But I've seen the role of the autosiban. It really works and it helps in implantation. It prevents the uterine contraction and really helps. As such, the implantation is very, very low in case of the severe adenomyosis, but atosiban sometimes help.
Okay. Thank you so much,
Any,
madam.
Yeah, because of the timing and everything, we just wound up. We had one more case.
Komal just wanted to, would you like to go to fifth case? I just wanted to make one point that adenomyomectomy is actually recommended for a very selective number of women, and there should be localized adenomyoma. Otherwise, this adenomyomectomy will not be helping. And secondly, I have seen many patients have come back to me with Mirena with the dysmenorrhea not improved, that they complain after taking Mirena.
Yes.
I've seen, sir, good results. The patient remains happy.
Yeah,
the size
most of them
the
have.
Majority there is.
Yeah, the size of the uterus is very important. So LNG for just a bulky uterus, it is very good. But when the uterus is quite large, LNG is not so good for those people. That is
Somebody
what is.
says two Mirenas at the same time. That doesn't work actually. That is not helpful.
Yeah, it doesn't work. Yeah. So Elagolix is coming now for such patients.
Individualize
Better
the
response.
patient also. We need to individualize because we cannot say that yes, we have it worked on one, it will work. So we need to evaluate properly and then decide like which patients it is going to.
Absolutely correct.
So
Thank you, Komal.
Actually,
I think it was a very good panel. And these are just the GCPR guidelines. We definitely remember the palm coin, go according to it. The treatment becomes very simpler. I think our panelist has given very good practical messages, and all flowcharts, everything is going to end. So the take-home message is diagnose first using palm coin, know which kind of AUB, tailor treatment to patient's goals, define failed medical therapy very clearly. You make it very documented with the patient that yes, the medical therapy has failed. Then consider the quality of life and not only just the bleeding. You need to know that what quality of life you are going to give to the patient. Surgery should be individualized and not autonomic. Like, yes, you will require, you will not. Yes, think about the patient, talk to her, discuss it out, and never miss malignancy. There are a lot of risk factors of malignancy, and we are having a thin line. So always try to be alert about this malignancy. So I'll end with a quote: the value of experience is not in seeing much, but seeing wisely, by William Osler. And thank you all, the panelists, our experts, and Dr. Lakshmi Madam and ICOG team for the opportunity. Thank you.
Thanks a lot, Dr. Lakshmi, for making me part of this.
Thank you so much.
Thank you.
Thank you.
Thank you, Lakshmi Madam, and thank you, ICOG team.
And our delegates.
Thank you,
Our
Lakshmi.
delegates are
Thank you so
eagerly
much.
waiting for the test link. So thank you all. Thank you so much. Now, technical team, please share the MCQ link in the chat box. Also share the QR code. Dear audience, please pay attention to your chat box.
Please share the link. Yes, the link is shared and the timer has already started. So pay attention to both. And where is the QR code? Yes, this is the QR code. So we all will be muted.
Thank you all our respected faculty for a fantastic second day's proceedings. We have 360 plus attendees attempting the post test today. Just a few quick announcements. The ICOG annual conference is in Bangalore this year, 22nd and 23rd of August. Those of you who are in the audience and who are not yet fellows of ICOG, please do apply as soon as possible. 15th of July is the last date. The ICOG office staff is always there to help you out. The link has been shared in the chat box. Plus, there's also a QR code for those of you who prefer the QR code scanning. And if Dr. Sheila Mane ma'am were here, she would inform you about the pass registry, which has recently been started. The link is available on the ICOG website. Request all of you who are especially in medical college and teaching hospitals to contribute your cases for the pass registry. Hello, madam. Good evening. It's nice to see you. I just made the standard announcements. You're muted, ma'am. I have sent you an unmute request.
I'm in marathon meeting. Hello,
You
Rekha.
are in one
How are
meeting
you?
after another meeting.
Rekha, how are you, beta?
Yes, madam. Somewhat. If
Take
you
care.
leave me
Take care.
alone, I'll sit and cry. That's all.
No, it's okay. Take care.
Yes, ma'am.
And nice, very nice. Okay, nice discussion. Panel was also very good. Today, I had a scientific committee meeting, then I had ethical committee meeting, and this also. Baap re. Lakshmi, kasrat kar
I
rahi
am
hu.
used to logging on 3 devices simultaneously when I was ICOG chair.
I know.
Fortunately, I'm logged in only from one device at a time.
At a time. At a time.
At a time. At a time.
Shall I
Hello,
log out, ma'am?
good job, Madan. Good
Yes,
job.
thank you. Thank you so much for the opportunity. You are
Nice
always a
discussions.
marathon runner.
Yeah. Now I have to start running also. I have to lose weight.
Till August,
Hi,
till your
Komal.
conference.
Pardon?
Till your conference.
Nice to see Sheila madam. Hi.
Hi. Till my conference, though, forever.
Oh, yeah.
In all aspects.
Being fit is always there.
Where is Ashish has left, huh? Ashish Mukherjee.
As usual, Sukirti is number one. She's finished earliest. Ipsita also. Thank you, Ipsita. Sukirti.
Looks like MCQs are very simple, Pratik.
I know.
They all paid
These are
attention.
designed to be simple, madam. We want
Yes,
more
and they
people
all
to
paid
pass. We
attention.
want more people to get the certificate.
Yes, but they paid attention to the faculties. That is why also.
Yeah.
Good. So happy.
Many
People are
people
submitting so
submitting.
fast.
Yeah, good.
Next time you can give 10 minutes, Pratik, instead of 15.
No, ma'am, we have to keep that as a standard for the certificate courses throughout because there are many people who
Okay.
log in late and then they complain कि खत्म हो गया.
Oh, yeah.
Now you
I
send us
know.
the certificate because we logged in.
They keep asking about the link and all.
You'll
Yeah, I
be
understand.
surprised in the last 6 months how many messages on WhatsApp, phone calls I have got for just that one certificate.
I know.
I need to have an answering machine on my phone. If you're calling regarding a certificate, then I will direct you to the appropriate authority.
Like like banks and call centers. Indigo का website पे calling center, yes. Please send the link. Please keep posting link again and again in the chat box.
So these are people who have logged in late, especially just for the post test. That's why they can't see the
Yes,
previous
yes.
messages regarding the link.
Yes. Got it.
So I'm happy to see some new names in the audience this time. And last time when I did the infertility course, I actually took people's names. Thanks to all our GCMs who have joined despite not being faculty. Dr. Upma has been here right since 4 o'clock. Thank you, Dr. Upma. Appreciate it.
Thank you.
We welcome everybody to Bangalore for our ICOG annual conference.
Sangitla madam,
First
Sangitla.
announced already?
Already announced.
Very good. Please send first day MCQ link. Sorry, dear. Do 2 days. Okay. At least do 2 days.
Very lenient ICOG chair. Good.
So this year we have introduced that anybody who attends and is there for at least 2 hours on each of the 3 days, we will give them a certificate of attendance. May not be the credit point certificate, but at least a certificate of attendance.
Great.
I think majority are finishing fast. Done.
Can you attend ICOG conference if you are currently MBBS students? Of course, why not? Please welcome.
You will
The
be
more
our
the
young
merrier.
talent. You will be our young talent. Please let us know.
I'm sure we will also learn from you.
See, I'm going to have a session on continuous, what is that? Education, medical education, CBME. Competency, Upma will know the long form. Competency-based medical education. There is going to be a panel and he can become a, if he is the youngest person, we'll make him a panelist. Please note his name, Pratik.
Yes, ma'am. Manisha Kulkarni is saying attended promptly since 6 months all certificate courses. I think we will honor you and felicitate you at Surat with a special
Bangalore.
certificate.
Great.
No, directly at Surat. If you attend all 12 certificate courses, then we will honor you and felicitate you specifically at the Surat AICOG.
QR code, you want the link? Somebody is asking why QR code. Do you want the link? Again, put the link in the chat box, Shreya.
Some people prefer QR code, some people like links. It depends. We have to cater to everybody.
So, बहुत लंबा treatment है.
Where do we search for ICOG points? On the certificate that is issued to you. They are mentioned on that.
I think link has also been put now.
The timer shows 6 minutes and 25 seconds. Yesterday's test we can't send it today because the answers have already been discussed yesterday, unfortunately. What is the benefit of ICOG points? The benefit is that you qualify for the fellowship earlier.
If you become a fellow and tomorrow you start a center, you can take fellows. Okay? Go to ICOG website and see all the details.
This certificate will provide ICOG points or not. Yes, of course. If you've not read the flyer properly, please do read the front page of the flyer. On every flyer for every certificate course as well as our web series. From this year onwards, ICOG is granting credit points in an effort to make more people come into the mainstream and become FICOGs.
Dr. Pratik, I have a query. Many people have applied. Some are not able to come to Chennai. So they will get their certificate in Surat only, no? they will not, unless they
Bangalore.
come for the convocation, it will not be confirmed.
Bangalore they can.
Yeah.
But in Bangalore, she is not able to come.
Surat.
If they are not able to come, let them communicate with the office with an official email saying that they are not able to receive it in person at Bangalore and they would prefer to receive it in Surat instead.
Okay.
And accordingly, we will
That's what
finalize that list. In fact, we are working on the pamphlet and the convocation card right now in the background, Dr. Upma, and we will finalize that very soon in a couple of weeks' time. And this year, Dr. Chilamane has introduced the pamphlet RCOG style, where the entire names of all the fellows as well as the members and the honorary fellows are also printed, which is a nice memorabilia for people to carry back.
Yes, that's very
Yeah,
nice.
we printed one in Delhi last time.
Yeah. We'll do it for Bangalore as well.
Yes, we will.
How is the certificate issued? The certificate is sent to you by email. This is printed in the flyer for the AUB certificate course. We have somebody who's logged in from Pakistan. Yes, you will receive your ICOG certificate. It will be sent to you via email. It's not a physical certificate anymore for reasons of logistics. And we send it to you by email. As long as you're a FOGSI member, you're eligible. As long as you're a FOGSI member, Dr. Chahana, you will receive the certificate. How to access the ICOG official website? www.icogonline.org.
No, that is okay. Even if you are not a member, you can appear here. Fine. You will get ICOG points.
Can anyone become ICOG member without becoming member of FOGSI?
No, you cannot.
So
You have to
MBBS,
be a FOGSI member.
you have to be FOGSI member because
You can be a FOGSI category B member, need not be a category A member with voting privilege.
so MBBS, they will not get FOGSI because you have to have a something
degree.
in gynae obs to become FOGSI member.
You can show that you've applied for a
No, B
postgraduate.
category.
Like I
B
told you.
category.
You'll become a category B member.
No voting rights.
ICOGonline.com and ICOGonline.org. Both of the URLs are valid. Category B is a membership which is devised for postgraduate students and medical students. They do not have voting privileges, but they are still considered members of FOGSI.
But they have to make the payment to FOGSI to become category B. They have to pay the fee.
Correct.
Yeah.
Absolutely.
FOGSI does not have direct membership. They have to become category B member of their society.
Off-label use of two Mirena placed simultaneously. I think this is a very good question. But I don't think our panel moderators and experts are here to answer it.
Tomorrow they can pose the same question and there will be many experts who will be
But then why stop
able
at
to
two? We can put three Mirena also.
Everything, all the programs are available on ICOG website. You can just click on that and watch even the earlier programs.
So day one MCQs are not possible. We cannot attempt them now because the answers have already been discussed. We have 1 minute to go.
3 months ಇದು ವರ್ಕ್ ಆಗುತ್ತೆ 3 months ಆದ್ಮೇಲೆ ಇನ್ನೊಂದು ಹಾಕಿಸ್ಕೊಳ್ಳಿ
ಇಲ್ಲ ನಮ್ಮ ಮಕ್ಕಳು ಬೇಕು ಅಂತ
ಮತ್ತೆ ಸ್ಟಾಪ್ ಮಾಡಿ 3 months ಆದ್ಮೇಲೆ ಏನು
Only 1 minute 58 seconds left.
Two months ಆಯ್ತು.
So is Dr. Shobha doing it or Lakshmi Madam is doing
3
the
months
answers?
ಆಗಲ್ಲ
I am reading the answers.
ಸ್ಟಾಪ್ ಆದ್ಮೇಲೆ
Pratik.
4 months
Alright.
ಆಗಲ್ಲ
I will do it.
ನಥಿಂಗ್ ಟು ವರಿ ಪೀರಿಯಡ್ ಆಗಲ್ಲ ಏನು ವರಿ ಇಲ್ಲ.
So Dr. Ritu, if AOJD has sent your subscription to FOGSI, then your number will already be there. Get in touch with the AOJD office
ಬಿಸಿನೇ
secretary
ಕುಡಿಮಾ ಕೋಲ್ಡ್ ಪದಾರ್ಥ ಏನು ತಗೊಳ್ಬೇಡ.
or with the FOGSI office secretary. They will be able to help you out.
Online series lectures, if you are not a fellow anywhere,
You can still
have to pay
apply for
10,000.
fellowship for this year's convocation. The last date is 15th of July, as I just mentioned 10 minutes ago.
No, one more thing, they are asking for fetal medicine series. Then you have to pay 10,000 rupees. And then attend the classes.
The link that I've posted is the link for application of fellowship and membership of ICOG. I will hand over back to Dr. Lakshmi to take us through the answers.
Yes. Please share the answers. Yeah. थोड़ा उसको expand करो श्रेया, make it bit bigger. It's very small font. Technical team,
You can zoom in.
I can.
Yeah.
I was not paying. So the first question, just zoom in. The first question was first line drug for acute heavy menstrual bleeding for hemodynamically stable patient. The answer is B, that is tranexamic acid. Second question was tranexamic acid works by, the answer is C, that is antifibrinolytic action. Third question was NSAIDs reduce menstrual blood loss by, the answer is B, by reducing the prostaglandins. Fourth was most effective long-term medical therapy for HMB. The answer is C, that is LNG-IUS. Fifth question was combined oral contraceptives. They act by, answer is B, that is by suppressing ovulation and stabilizing endometrium. Sixth was cyclical progesterone is mainly used in anovulatory cycles. The answer is D. 7. Selective progesterone receptor modulators, they are mainly used for, answer is B, that is fibroids. 8. The first line management in mild AUB without anemia is observation or medical therapy. So the answer is B. Ninth one was best option for AUB in a woman desiring contraception. The answer is B, that is LNG-IUS. 10th question was best option for AUB with PCOS. The answer was OCPs. That is B. The 11th question was AUB in perimenopausal woman who has completed her family. The answer is B, that is LNG-IUS or surgery. Ideal therapy for woman who wants fertility preservation. The answer is C, that is medical management. Breakthrough bleeding on OCPs is managed by increasing the estrogen dose or checking the compliance of the patient. So the answer is B. Long-term GnRH analog use requires add-back therapy. Every speaker has highlighted. So the answer is B. Most important factor in choosing therapy in cases of AUB is B, that is the patient's age and fertility wishes. Next question was indications for surgery in AUB. The answer is B, that is failure of medical therapy. 17th question was endometrial ablation is contraindicated in which cases? So it is contraindicated in those patients who desire future fertility. So the answer is B. The best treatment for submucosal fibroid causing AUB, the answer is B, that is hysteroscopic resection. Myomectomy is preferred when fertility preservation is required. So the answer is B. And the last question was route of hysterectomy depends on the uterine size, pathology, and the surgeon expertise. So answer is B. I am sure you all must have scored 100% marks, as every faculty, they answered all these questions in their talks and panel discussion. Yes, Dr. Sheila Mane madam and Pratik, you all can give your remarks before we wind up.
Excellent second day's proceedings, fantastic course, and I think we are getting better day after day. Thank you very much to all our esteemed faculty for contributing your valuable knowledge and taking time out from your busy schedule to share your knowledge with all of our delegates. Again, we are going to have around 500 odd people for the last day's proceedings, and I think that will be the icing on the cake. Look forward to seeing all of you very soon tomorrow.
I will just say thank you all, everybody here. Thank you.
Yeah, so tomorrow we look forward to see you all at sharp 4 p.m. Tomorrow we are focusing mainly on the complex AUBs, acute AUB, postmenopausal bleeding, and adolescent AUB. And there will be very interesting case-based panel discussion as well. So don't forget to log in tomorrow at 4 p.m.
Bye, everybody.
See
Goodbye.
you all.
God bless.
Bye.
Bye for now.
Bye, everybody.
Thanks, Dr. Lakshmi, Dr. Sheila, for inviting. Thank you.